Good morning to you all. Can you hear me? Hello, can you all hear me?
Can hear you.
Yes, good morning. Welcome to our ZSOG second quarter scientific Zoom CME. The title of today's CME is Advancing and Promoting Growth of Subspecialties. We have a full day's program of engaging presentations, and I hope you'll be able to stay with us for most of them. My name is Dr. Abigail Lupepe, and I'll be chairing this first session, which is fetal medicine. We have three presenters who will be giving us 20-minute presentations. Thereafter, we will take questions during the discussion period. During that period, you may raise your hand or you can type your question in the chat box. Please also do take note that we have a registration link that is in the chat box. So please do head to the registration link so that you can be accredited with your points. In the meantime, I request that we all mute our mics so we don't disturb our presenters. And our first presenter this morning is Dr. C. Madembo, and he'll be presenting on the epidemiological profile of obstetric ultrasound attendees. Dr. Madembo, I don't know if you're ready. If you're ready, the floor is yours.
Okay, thank you very much, Dr. Lupepe. I will be sharing my screen. All right, thank you very much, Madam Chair. Good morning, colleagues, friends, seniors here present. This morning, I'm going to be sharing on epidemiological profile of obstetric ultrasound attendees, a primary care setting experience. That is in Harare City. Harare City, we started to implement offering obstetric ultrasound scanning services from late 2019. My slides are not moving. Sorry, can I share again? My slides are not moving. Okay. Sorry, my slides are sticking, they are not moving. Okay, can you see my presentation? Okay, so as a city, we started can you see my presentation?
No, we can't.
You can't?
We can't see.
Okay. All right, let me share. All right, is it coming out now?
Yeah, it's now clear.
Yes.
But not on PowerPoint. I mean, not on slide share. All right. So as a city, we started to offer obstetric ultrasound scanning services late 2019 as part of the Ministry of Health and Child Care rollout plan for obstetric ultrasound services. This came with the realization that ultrasound, I mean, antenatal care is the most utilized maternity service with earlier research showing that we have an AAC coverage of estimated around 83%. It is against this background that we took this as a platform to promote health and ensure safe delivery of mothers in the city. And it also, we noted that ultrasound services play a critical role in this regard by identifying at-risk pregnancies and then directing those at-risk pregnancies to deliver in a hospital setting. So, and also noting also that ultrasound has a role in managing obstetric complications. We're talking things like ectopic pregnancies, things like antepartum hemorrhage, placenta previa. So this is the conceptual framework concept note that we've been working from. We are in a setting of poor socioeconomic status. And because of the poor socioeconomic status, there has been unavailability of ultrasound services to pregnant women in most settings in this nation. And also lack of skilled service providers to offer ultrasound screening services. Because of unavailability of ultrasound services, you end up having undiagnosed multiple pregnancies, undiagnosed placental abnormalities, ruptured ectopic pregnancies. And because of this, you end up having obstructed labor, hemorrhage, bleeding, and the end result is a poor pregnancy outcome. So we started offering obstetric ultrasound service, like what I said, late 2019. And because what we have learned also with the encouragement from the fetal medicine unit in Harare, both Harare Parenyatwa under the leadership of Dr. Virenga, we did not want just to scan women, but we wanted also to do data capturing of all the women that we have scanned. Dr. Virenga always said that we don't want to do zero tillage. Zero tillage is a concept where people just go to work, work and go home, go to work, work and go home, go to work, work, without never analyzing the work that we are doing. So what we did is we created or we generated a data capture, an electronic data capturing tool in EPINFO under the version EP7. So what happens is, as we are scanning patients, data is collected at the same time. So there's real-time data capturing by health service providers as scanning is happening. So the design of this study is a kind of prospective cross-sectional study, both descriptive and with an analytical component. Basically, we do image documentation during the scanning, both sine loops and static images, storing images of standard planes. We are using a very simple ultrasound machine with basic 2D grayscale imaging with sine loop, M-mode, and Doppler capabilities. The machine that we are using is both a transabdominal and a transvaginal probe. And this is the pictures of the machine that we are using. So to date, okay, we have scanned more than 417 patients, but from the time that we started doing data capturing, we have 417 records that are in our system. So we cleaned the data by deleting multiple entries and also removing entries with missing information. So we're left with 417 records for analysis. And we analyzed this data using EP7, doing both univariate and bivariate analysis. Not much of bivariate analysis because of some reasons. So this is the data set that we are using. So the first component, basically, it captures more of demographic information of the women that we scan. Then the second component, we capture indications for the scanning. The third component, we take relevant past medical surgical history and obstetric history. We have also added this component where we capture information about prior cesarean section, prior uterine surgery, taking cognizance of the fact that women with these are at higher risk of developing morbidly adherent placentas, technical conditions. And it has another page, but because of time, I will not go into that. So these are our results or our findings from the women, the 470 women that we have scanned so far. So median age is 26 with a median parity of 1, median gravidarum of 2. Most of the women that we have scanned have at least attained secondary education up to Form 4, that is 81.3%, followed by tertiary, which is 7.1%. And these are the milestones that we have achieved so far. So basically, as a city, we have received 2 machines. One is stationed at Edith Obermann Polyclinics, and the other one is at Warren Park Polyclinics. So this is the trend distribution of the number of women that have been screened over time at the 2 facilities by the healthcare workers who have been trained. We have 5 healthcare workers who have been trained, 2 nurses at Warren Park, and 2 nurses meant to be at Edith Obermann and a doctor. So these are the number of women that have been screened over the time. And 72% have been screened at Edith Obermann, with 28% being screened at Warren Park Clinic. These are the indications for scanning. So we find that 65% of the women that we have scanned, the main indication would be to assess the fetal well-being. Pregnancy dating, 42%, and those are the other smaller indications. Big, small for deaths, and midwife or staff, healthcare workers wanting to know the presentation, maybe it's near-term diagnosis of multiple pregnancy. And in terms of one of the questions on our questionnaire is the gestational age at booking. So you find that the median gestational age at booking is around 25 weeks, with a lower quartile of 21 and an upper quartile of 30. So it is this, against this background, that with the modern trend that we want to invert the pyramid of care, there's a lot of work that needs to be done so that we don't get women booking around 25 weeks. And in terms of the trimester at first scanning, so we find that majority of the women that we have scanned so far have been scanned in the second trimester, which is about 46%, and first trimester, third trimester, which is about 45%, and only 9.5% have been scanned in the first trimester. So a lot of work still needs to be done so that we invert the pyramid of care as the modern ANC is talking about. And in terms of risk assessment, we assess the risk by taking a history. Majority of the women that we have scanned, no risk factors. 13 had PIH, 5 had history of miscarriages, and those are the other small histories. And majority of the women that we have scanned are HIV negative, 10% HIV positive, and 8% positive and 10% with an unknown HIV status. Among those who were HIV positive, 72% were on ART and 28% were not yet on ART. The reason for being not on ART, they were newly diagnosed. And in terms of family history, it's another important aspect, especially as scanning. A history of heart disease, history of PIH, diabetes. Majority had no history of these chronic medical conditions, with a smaller percentage responding to chronic hypertension, diabetes, and PIH. And in terms of this one, we recently added this one: prior cesarean section and prior uterine surgery. So far, 150 have responded positive to prior cesarean section. We scan. So here are our scanning outcomes. From the scanning of the 417 women, 96% were singleton and 4% were twins. So 96% were singleton and 4% were twins, with about 82% encephalic presentation and about 17% breech, and the other smaller percentage transverse and oblique. The scanning conditions were regarded as good in about 85%, but we were limited by maternal habitus, the aspect of obesity in 6%, and limited by prior cesarean section scar in about 0.7%. After scanning, we have to date your pregnancy, give the gestational age. So in about 47%, the pregnancy was finally dated based on the LNP, because the LNP and the scanning findings there was no discrepancy in the LNP and the scanning findings. In about 27%, dating was final pregnancy dating was based on T3 scan, and in about 21 on T2 scan, and in about 5% on a T1 scan. Then the placenta was on the upper anterior in 44% and upper posterior in almost 45%. And this was the location of the placenta in the other rest of the women. This one, like what I'm saying, it's still an ongoing data collection. We also intend, among those women who have had prior uterine surgery, prior cesarean section, we intend to analyze issues to do with the placement of lacunae, bridging vessels, placental bulge, clear zone, myometrial thinning, neovascularity, and bladder line interruption. Basically, these are features to do with a morbidly adherent placenta. And I'm also glad we recently got another machine, a third machine that we are going to be using with color Doppler capabilities. So it is going to allow us to see issues to do with the bridging vessels and issues to do with neovascularity. But with even grayscale imaging, you are able to see some of these things. And we also want to analyze where we'll do some bivariate analysis in terms of looking at is there a statistically significant relationship between women who had a prior cesarean section scar and sonographic features of morbidly adherent placenta. Same applies to women with prior uterine surgery and sonographic features of morbidly adherent placenta. Amniotic fluid, majority of women had normal amniotic fluid findings with a small percentage having oligohydramnios and polyhydramnios. And these were our final diagnosis and conclusions in the women that was normal growth in majority, and SGA, multiple pregnancy, oligohydramnios, polyhydramnios, and LGA in the other smaller groups. So what has been the impact of introducing these services in Harare City? We have managed to reassure the women and even the healthcare workers that there is no need for further scanning in about 44% of the women that we have scanned. In 48%, we have been doing some follow-up growth surveillance scan. And in about 8%, we have referred them to the fetal medicine units for the various reasons like multiple pregnancy, SGA, etc., etc. And these are just some of the images that we have been taking. This is an abdominal circumference done and giving a gestational age of around that 30 weeks, 3 days. Same against abdominal circumference done. We have been trying to do image optimization with standardizing our images to the standardized manner with the strict quality criteria required. This is a head circumference. You can see a rug-shaped head. We can see the cavum septum pellucidum, posterior horns of lateral ventricle, and the thalamus. And these are the gestational age, biparatum diameter based, and also head circumference. This is a case with severe bilateral ventriculomegaly that we picked at Warren Park Clinic, and we referred to Parenya to a fetal medicine unit. femur length. The simple machine is also able to do some Doppler. This is just one case we did an umbilical artery Doppler. You can see here the PI was 0.73 and we reassured the patient. And we have been able, among the women that we have been doing this Doppler like the umbilical artery, in about 6, we have noted some reversed end diastolic flow. We then have to refer them to Parignatoire and stratify them by growth pattern. You find that you still find even those with the reversed or absent end diastolic flow among the AGA and majority in the SGA. And so, anyway, we referred them to Parignatoire for further care. This is MCA Doppler. The same machine is also able to do mid-cerebral artery Doppler. It's also able to do ductus venosus Doppler. These are some images that we have been taking, even with the same machine. Anatomy scans. This you can see orbits in these 2 images. Heart scanning, apex, position, situs, 4-chamber view of the heart, left ventricular outflow tract, right ventricular outflow tract, and 3-vessel trachea view. So, ladies and gentlemen, in the last 1 or 2 minutes, this is a first trimester scan. We're measuring the crown ram length, measuring 77, giving a gestational age of 13 weeks, 5 days, and the head showing the butterfly sign there. This was a case of some multiple pregnancy. You can see the lambda sign there. A multiple pregnancy, you can see the membrane separating the 2 fetuses. One is here, the other is here, another case of multiple pregnancy. So in this time that we have been offering these services, it has allowed us timely referral of cases like multiple pregnancy, morbidly adherent placenta, placenta previa, abnormal lie, suspected fetal growth restriction. It has been it's also an opportunity for us for early screening and prevention of leading causes of maternal or perinatal mortality morbidity, like preterm death, preeclampsia, growth restriction, and also early pregnancy dating by doing CRILs like the case that I showed you, and viability assessments post-deaths. So it is against this background that we have come up with our protocol that we encourage the midwives, even in other clinics that are not offering these services, when they refer a patient, they should know what they should be referring a patient for, especially when they need scanning. So we say the following should be offered: scanning services as they fall in the high risk category. Anyone with those obstetric syndromes like hypertension, diabetes, preterm birth, any woman with a history of SGA, LGA, stillbirth, early neonatal death and miscarriages, recurrent pregnancy loss, cervical assessments can be done because the machines have transvaginal ultrasound, probes which can measure cervical length. Previous baby with major defects, suspected malpresentation, suspected multiple pregnancies, big, small for deaths, reduced or absent fetal movements. So in a nutshell, these are some, and if we happen to get them early, we recommend them to be done early pregnancy T1 scan where they can be dated CRL, and even early fetal anomaly scans. T2 scans around this time where we will be doing the anomaly scan and a growth scan. Documentation remains an important aspect in our scanning. No job is finished until the paperwork is done. So we are also, initially we were giving them handwritten reports, but of late we have started also typing our ultrasound reports. So ladies and gentlemen, this is our experience with obstetric ultrasound scanning, and I want to thank the following individuals and organizations for supporting us in this endeavor. Thank you very much. Over to you, Chair.
Thank you very much, Dr. Madembo. That was an extremely interesting presentation, showing us some very insightful statistics from Harare City. Thank you so much. This is very impressive work that you're doing. We will quickly move on to our next presenter. Any questions or comments, please can we reserve them for the discussion session. Right, our next presenter is Dr. H. Dube, and he will be presenting on the topic, My Babies Were Born Red and White, Controversies in the Diagnosis and Management of Antenatal Taps in Twin Gestations. So the floor is yours, Dr. Dube, if you're ready to share your screen.
Thank you very much, Dr. Lupepe, for the kind introduction. I don't know if people can see my screen. Is my screen visible?
Yes, it is.
Thank you very much.
Thank you.
Hello.
I think you may continue, Dr.
Yes,
Dube.
thank you very much for the kind introduction. I'm going to present on the controversies in the diagnosis and management of antenatal twin anemia polycythemia sequence, that is TAPS in twin gestations. So the outline of my presentations will be a brief introduction, and then I will introduce you to the red and white babies who were born with rose wine and ketchup bloods, the history of TAPS, the background, a bit of pathophysiology, the diagnosis, the management, the controversies, and some of my references. So as a starting point, TAPS was originally described in 2006, but however, it remains open to a lot of controversy in its diagnosis and management. However, there's been a lot of progress in research over the last 15 or so years for a universal definition, screening tests, classification, and management, but a lot of issues are still in dispute today. So as of today, and there's been an establishment of a TAPS Foundation, which is for research, for learning, and TAPS advocacy. And I'm very grateful to the TAPS Foundation for their generous invitation for me to come to Netherlands to be part of their work and to see some of their work and the work that they are doing around TAPS at the Leiden University Medical Center. So the discussions are still at elementary stage, but at some point, they invited me to come for some research work there and to learn as well. So it may also possibly be a good learning opportunity for me. So what is TAPS? So TAPS arises from intertwin anastomosis that are connecting two fetal circulations. And it is said to be caused by slow transfer of blood from one fetus via very small anastomosis. And these anastomosis are thought to be very few, to about 3 in 4 anastomosis. These anastomosis actually facilitate a unidirectional fetal transfusion of approximately 1% of the fetal blood volume, approximately 5 to 10 mils in 24 hours. And this slow transfusion actually promotes anemia in one fetus and polycythemia in the other. And it has been shown that there are no serious differences actually occur in the amounts of amniotic fluid. So if you look to your right there, at the top there's a healthy monochorionic twin gestation. Sorry, let me try and get a pointer to work. So if you look at the top there, this is a healthy monochorionic picture of twins where with baby B. There is actually bidirectional flow of blood through the interconnecting vessels. But at the bottom there, when TAPS now developed, there tends now to be only a unidirectional flow of blood, such that there is outwardly a flow from baby A to baby B. And baby B then becomes polycythemic and baby A becomes anemic. So this is thought to be the mechanism through which TAPS occurs. Sorry. So even after the same placentas have been studied, you can may not be able to see these interconnecting vessels through a naked eye, but with placental dye injection studies that are done postnatally, you can actually be able in this picture to see these sort of minuscule vascular connections between the green and also between the red. So these are the so this is in the spontaneously occurring form of TAPES, and this is actually in post-laser TAPES. So you can actually develop spontaneously or post-laser. So in this other picture here, you can actually quite see the laser ablation spots that we actually carried out on this in this placenta in utero. But you can actually see even in this zoomed image that there remains, even after post-laser ablation, that you can actually, there remains some interconnecting vessels. And these are the vessels that are actually thought to contribute to the formation of TAPES. So these are not my pictures, these are pictures that I obtained from the TAPES Foundation that are actually going, this has become TAPES world, and you're actually able to appreciate a very pale, small donor twin and a red puffy recipient twin. So this is an image that is actually top in most search engines, and it represents exactly what TAPES can do. So these are the babies actually born on the 20th of December, and when they were born, they actually 20th of December 2013. So when they were born, they actually looked quite different. One seemed to be very pink, and yet the other one looked to be quite pale and sort of white. So the one on the right of your screen is Emily, and the other one is Mathilde. So they've actually become sort of iconic in terms of describing TAPES. So this is their placenta. So you can actually see here that there's quite different in terms of their appearance, with one part that looks paler and the other part that looks quite brownish and quite a bit plethoric. So these are the babies who were said to have been born with different bloods. One was ketchup blood, meaning Mathilde, and then the other one a sort of rose wine appearing blood. So this mother, the story of this mother is that they looked quite to be a normal pregnancy until 24 weeks, when they were diagnosed with the twin-to-twin transfusion syndrome. They were then sent to the Leiden Medical Center, where at around 31 weeks, they actually developed, when they followed up, they actually then developed the TAPES. And at 31 weeks, they actually delivered prematurely. Emily was actually weighing 1,100 grams, and the Mathilde was actually weighing 1,600 grams. Spent quite a lot of time in intensive care unit and being followed up, and they were actually discharged. Emily was discharged at 6 weeks, and Mathilde was actually discharged at 5. They received intrauterine, they received partial exchange transfusion. This other one received transfusions. They actually suffered quite a lot of anemia and some signs and symptoms of prematurity. So how did these sort of TAPES begin? So I would want to take you back to an article that was published in March in 2006, where Romain Roby and his colleagues actually noted that there were some late fetal complications that developed after some pregnancies were actually successfully treated with selective laser coagulation of the chorionic plate. It was not until 2007 that the actual acronym of TAPES was actually formulated, where Lopre and his colleagues actually described twin anemia polycythemia sequence in monochorionic twin pairs without oligo or polyhydramnios sequence. So in 2006, it was first described. Then in 2007, that's when it was actually given a name. So what do we know now? We know now that TAPES can occur spontaneously in 3 to 6% of otherwise uncomplicated twin gestation. We all know that in 2 to 16%, those follow laser, but we know also that it can occur after the Solomon technique has been used for laser ablation, where the equator is also coagulated after selective fetal laser ablation. And most of the antenatal TAPES cases are diagnosed in the 2nd or 3rd trimester, but 40 to 63% of these cases are not detected antenatally. So there's still quite a lot of work to be done, a lot of research to be done, and a lot of improvement to be done so that most of these cases are detected. And therefore, TAPES remains an underdiagnosed, underestimated, and underscreened condition. So why are we talking about this subject today? Because we know that there are both neonatal and pediatric outcomes that are quite severe, with associated with a lot of morbidity and even mortality in most of these pregnancies after TAPES. So in the recipients, these can range from a polycythemia, viscosity syndrome, limb ischemia, skin necrosis, thrombocytopenia, cerebral injury, and even motor delay. And in donors, they are prone to anemias, reduced total protein and albumin, renal dysfunction, bilateral deafness, even neurodevelopmental impairment. So that's why I thought we need to discuss this so that we may be able to see and to map a way forward. So how does one make an actual diagnosis of TEPS? So the mainstay vessel of interrogation remains the middle cerebral artery peak systolic velocity. This is what we are showing on the extreme left. So it actually uses a principle that thin blood flows at high speed and thick blood flows at low speed. So it is actually this differential between the speeds of the blood through the middle cerebral vessel that is actually quite important. In such a way that you can literally plot the velocities on a graph for the donors and also plot the velocities on the graph for the donors and also plot for the recipient. And it is the differences between these two or the peak systolic velocities that you should then be able to plot. And then if there's significant differences or there's significant values, then you are then able to make a diagnosis. I'll come back to that. However, there are also some ultrasound scan diagnosis findings that can actually help in coming to this diagnosis. So there is a description of a study, a sky liver, a cardiomegaly, and also the dichotomy placenta. What we mean by dichotomy is that you can actually look at this, we can actually find that the side of the recipient actually looks quite darker than the side of the donor. So you can actually literally see some of these features on the placenta where you have a monoclonal placenta, but the colors therefore don't look quite the same. And it's been shown that the stereo sky liver is found in about 66%, cardiomegaly in 70%, the dichotomy placenta in about 44%. So these are just some additional signs that you may actually use over and above the middle cerebral artery. So postnatal diagnosis, you can actually make a postnatal diagnosis by collecting blood from the babies, and it is suggested that we collect this from the umbilical vein rather than pricking the babies themselves. Some of these may actually be quite small and really needing tender care. So what you're going to see in the blood of the donor now, you're going to see they are quite anemic, but they have a high reticulocyte count because of this chronic transfusion that has happened in them actually trying to build up their red cell stores. Conversely, in the recipient, you're actually going to see a quite plethoric blood with a high hemoglobin, polycythemic, and a low reticulocyte count. So again, if you examine the placentas, just by turning around the placentas, actually, you could actually be able to make sort of an inference, not necessarily a diagnosis, but an inference. Where in an uncomplicated twin pregnancy, the placenta really looks quite beefy red and homogeneous really throughout. In an acute peripartum TTS, you may see some differences, but it seems also to be quite the same. Whereas in TEPS, you can actually see quite a demarcation between the two sides of the placenta, where one looks quite pale and the other one looks quite reddish. So you can actually, just by turning placentas, be able to see. And indeed, there was a study which was done in Pregnancy Fetal Diagnosis and Therapy Journal in 2016, where you can actually use imaging and technology to be able to calculate the actual color difference ratio between the two sides of the placenta, and actually now come up with sort of a diagnosis, as this has been shown that it can actually correlate with the hemoglobin differentials in that placenta. So we now know also that there's a TAP staging that people can actually use to determine the severity of the disease. But again, as you would have known from the twin-to-twin transfusion, that the severity of the staging system does not necessarily correlate with the outcome of the babies. But traditionally, people have actually used that if you find the donor matters of the middle cerebral artery peak systolic velocity above 1.5 and in the recipient less than 1 can actually make the diagnosis of TEPS. And then so you can actually stage using the matters of the median of the middle cerebral artery peak systolic velocity from stage 1, 2, 3, 4, and 5. So I want to also reiterate that this has actually gone through quite a lot of a lot of changes over the past 5 years, but these are the 2 stages at the moment that actually have been shown to be in sort of agreement or to be used widely throughout the world. So the new staging system now, what happened is that people then realized that some of the recipients with multiples of the median above 1 were actually found to be quite sick even at delivery. So it's no longer really now necessary for you to use the actual cutoffs, but to use what they call the multiples of the median difference in delta MCA PSV, that it is actually more like the difference between the 2 values that is actually significant rather than the actual cutoff. So now there's a new proposal of a staging system for stage 1 and stage 2 as shown there. So postnatally, actually, when you collect blood samples from these babies, you can actually measure in the two fetuses, and if there's a difference between twins that is greater than 8, that is stage 1, 11, stage 2, 14, and so forth, for stages 4 and 5. So even if you do the reticulocyte count as well, if there's a difference in reticulocytes of more than 1 as to 1.7, that is can also assist in the diagnosis of postnatal TEPS. So what are the management options? So it remains challenging. The optimal management is not clear. Is the fetal therapy center dependent? As of now, there's no RCT results to guide the treatment. There's really no universal agreement on screening, no consensus on when to start. But however, there are suggestions, there are options that are suggested that I'm going to go through shortly. So even if you go through international guidelines, there's also no correlation, there's also no agreement in what people ought to be doing in terms of surveillance. Society for Maternal Fetal Medicine in United States says that there's no difference, there's no evidence that monitoring for TEPS at any time, including more than 26 weeks, improves the outcome, so additional screening cannot be recommended. The NICE in England says do not recommend this for screening for uncomplicated monoclonic pregnancies, but for complicated monoclonic pregnancy, they seem sort of to lean towards people actually investigating and doing surveillance of these fetuses even more. ZSOG also states in their guidelines that uncomplicated monoclonic twins should have a first trimester scan and be scanned every 2 weeks after 16 weeks in order to detect TTS and TEPS in a timely manner. The RANSCOG from Australia and New Zealand, they will actually recommend screening with MCA PSV only after 26 weeks. So what are some of the treatment options? Treatment options could range from expectant management to preterm delivery, intrauterine blood transfusion, to laser, and also selective reduction. So, like I've said, that there's no RCT to be able to guide people in terms of what they ought to be doing. So there was a web-based registry for anonymous data collection from 2014 to 2019, whose results from 17 fetal therapy centers was actually analyzed. And they analyzed about 370 cases of TEPS in that study, where centers were actually supplied with credentials to enter the data into the online registry. And on the right side there, I'm actually showing the centers that were involved in this registry and this data collection, where the Leiden University Medical Center actually leads in these cases, because in Netherlands this is the only fetal therapy center actually that offers laser ablation. So almost all the cases actually go to the specialized center. So in the treatment now, the treatments were actually quite varied among these centers. 30% use laser, 31% we manage the patient expectantly, 11% they offered immediate delivery, IUT and PET 19%, and some, in about 8%, we actually offered selective feticide. So what were the results? They actually discovered that the issues of severe neonatal morbidity and mortality were actually very high across all treatment modalities or all treatment options, more so in the immediate delivery. I'm sure it can be explained from the issues of prematurity and the intrauterine therapy, where they had 49 and 46 respectively. But however, those numbers, if you look at on the left side, they remain quite high in terms of the morbidity. Even on the left, the perinatal mortality is also quite high in terms of TEPS. So it is a disease that actually is associated with a lot of morbidity and mortality, regardless really at the moment of what method one tends to use. But again, these results actually obtained from quite a heterogeneous group of centers who were using different techniques, and even a base that recruited these patients, they actually had quite different factors. So in their summary of these results, they say they did not find any perinatal mortality difference. So you could see 49, 46, 35, and 31, quite high figures. But then they say that they actually saw that neonatal morbidity was actually increased with the preterm delivery and the IUT group. Then that you could actually prolong the pregnancy with the expectant management, laser, and also fetal reduction. So they concluded then that the perinatal morbidity and mortality were high in all management groups, and there no international consensus on the optimal management of TEPS. And then they said the randomized control trial to investigate this was possibly the best option, and that it was urgently needed. So around the same time now, Asma Khalil, a professor of maternal fetal medicine in St. George's, actually also started to do a consensus diagnostic criteria through the Adelphi process, where she included amongst 132 international experts. Again, there was some disagreement and agreements as shown there on the extreme right, where they could not agree really on the gestational age at which to start monitoring. They also could not agree on the cutoff of the mid-cerebral artery peak systolic velocity or its discordance for prenatal intervention. But however, they agreed that the monitoring interval for the development of TEPS should be every 2 weeks. Then this brings me to the TEPS trial. It is actually a multi-center randomized control trial. It is actually currently recruiting, and the ages range from 18 years to 50 years, where they are basically looking at monochorionic twin gestations with a stage 2 and above. And their hypothesis really fetoscopic laser therapy will improve neonatal outcome by prolonging pregnancy. So it started on the 30th of April, 2019. It is estimated to be completed 30 April 22, where we'll probably get the primary data from that study. And the study is meant to be completed on 30 April 2024. And so those are the institutions that are currently involved in the study, amongst them St. George's, Birmingham Women's Trust, and also Leiden University Medical Center. So this is the flow chart where they want to recruit 44. They will then randomize them to laser treatment and standard treatment. Their primary outcomes will be gestational age at birth. They also look at perinatal mortality, neonatal morbidity, hematological complications, procedure-related complications, and neurodevelopmental impairment at 2 years. So it's quite a long study that is going to go 2 years, also post-delivery. So this may actually unify maybe the management options and also guide in terms of how these babies ought to be followed. So what are people doing in the meantime? Once the results are awaited? So there's some suggested flowcharts and algorithm that if you have a baby who's less than 20, if a pregnancy which is less than 28 weeks and stage 1, you probably may just do expectant management. It may suffice if you have less than 28 weeks, but the stage is greater or equal to 2, maybe laser treatment should be the way to go. If you are between 28 and 32 weeks, you then divide whether it's stage 1, stage 2, stage 3. You also look at whether is the TEPS progressive or non-progressive. And then you may then now decide whether to go to expectant management, to intrauterine therapy with PEP, with PET. Then if you are more than 32 weeks, I think most of the institutions really recommend steroids and then immediate delivery, especially if the TEPS is not progressive. But you may have also an option of going to expectant management with such fetuses. So what are the controversies really surrounding this at the moment? There are some who still believe that it is a sequence and not a syndrome or a condition. That's why it is called TEPS. It's polycythemia anemia sequence, not syndrome. That it is a form of TTS and there should be no differentiation between the two. That the natural history of TEPS is not clear, and so MCA VPSV screening cannot be recommended. That the actual diagnostic tool that people are using is not a lab test for TEPS, that people should look for something else to use. And that if you go looking for something to find it. So if you're going to offer most of those babies in uncomplicated monochorionic twin gestations and you're going to look for something wrong, you're most likely going to find it. That TEPS presents with other symptoms that will be visible via other tests and that there's no need to screen. And that TEPS is an unclear protocol. Then so why do you need to screen if you do not know how to treat? And that TEPS is incredibly rare, so routine screening is not necessary unless the patient is post-laser or having other complications. So they also conclude those who are putting sent in the SATSA to say that routine MCA-VSV Doppler screening results in premature births. So what did I learn about this past, current, and future controversies? I actually learned that even if you look at how nuclear translucency came to be universally recommended as a way of aneuploid screening, it actually went probably through the same processes. Even when Professor Nicolaides introduced the inverted pyramid of care, it was met with quite a lot of resistance. But we, as the world, I think going towards that. Even last week, I was actually in another Fetal Medicine Foundation webinar where people were discussing congenital diaphragmatic hernia in terms of where does the fetoscopic endolunar tracheal occlusion comes in. The results of the total trial, they were presented by Depressed and his colleagues. There was quite a lot of noise around this, a lot of controversies were raised. But then I learned that we need to embrace these controversies and these criticisms as we advance and promote growth of subspecialties in the ZSOG. Let us not look at them as controversies as such or criticism, but as a way and opportunities for research, for learning, and also growth for us and also our future generations. So I'm very indebted to these organizations. The pictures and images are from the TAPE Support Foundation, Leiden Invest Medical Center, Dr. Femke, Dr. Lizen Tolene for the illustrations, and the TAPE Foundation as a whole, and St. George's and Birmingham. Thank you very much, Chair. I'm done. Thank you, Dr. Lupepe. I am done. I'll wait for the questions at the end of the session. Thank you.
Thank you so much, Dr. Dube, for that interesting presentation. And thank you so much for refreshing our interest in this condition. And congratulations on being invited to participate in the TAPS research. So as we've already mentioned before, please can we either type our questions in the chat box, our comments in the chat box, or we can save our questions for the discussion session that's coming up after our next presenter. Please don't forget that we should go to the chat box and use the registration link so that we can get accredited for our CPD points. Our next presenter, let me just check if she's managed to log back on, is Dr. Ndagurwa. And her presentation will be on single intrauterine fetal demise in twins. She'll be giving us a perspective of the fetal medicine unit experience. I'm hoping that she's managed to log back in. Dr. Ndagurwa, are you with us? If she's not currently logged in, maybe we can take a few minutes at this point to take any questions or comments for the two presenters that we've had so far, whilst she's trying to log herself back in. Would there be any questions or comments that anyone would like to ask to our two presenters, Dr. Sima Dembo and Dr. H. Dube? All right, there don't seem to be any hands raised at this point.
Ranger has a hand raised.
Is there a hand? Sorry. Okay, there, yes. Sorry, please can you unmute
Go ahead
and ask the question.
Thank you, Chair. Thank you both to Dr. Madembo and Dr. Dube for their wonderful presentations. Dr. Madembo presented the experience of scanning in the city of Harare and found a percentage of agreement between the menstrual days and the scan of 47%. I'm worried that this is rather quite a low figure because anecdotally some years ago when we looked at the numbers of women that needed to have their dates changed from the city of Harare coming to the Harare ultrasound unit, we found that we only had to change dates in 16%. But in his case, they've had to change dates in 53%. I'm a bit concerned. I would like to know what algorithm they were using to compare menstrual dates and ultrasound dates. Dr. Madembo, is he?
Okay, thank you very much, Prof. Yes, I think in my presentation, one of the slides was speaking on how the pregnancy was dated finally. So I said in about 48%, the final pregnancy dating was based on LMP. There was an agreement between the LMP given dates and the ultrasound findings. So in the other 53% is either number one, the women did not know the dates, or number two, there was also a disagreement between what they said and the sonographic findings. And in one of my presentation, also I highlighted that the two major reasons for scanning, one was fetal well-being and the other one was pregnancy dating. So yes, pregnancy dating was also one of the major reasons why women wanted to be scanned, because some of them, they got pregnant, especially these days, maybe they are on ART and they are on family planning. The family planning fails while they are on ART. So it could be one of the reasons. So the dating had to be scan based because of that. But I also, I think in one of the presentations, I think Dr. Ndaguru did some time ago, she was saying in almost 50% of women, they don't know their dates. So which is actually also kind of in agreement with what we found, that in 48% the pregnancy and the LMP given dates were in agreement with the scan findings. And in the other 52, 53%, we had to date either based on a T1 scan, T2 scan, or T3 scan.
Okay, I think perhaps in future then you could find out, stratify by gestational age to find out how many women of those who come early will have their dates changed. Because maybe what has happened is that median gestation of booking is now very high. So if women are coming for the first visit after 26 weeks, then of course you probably have to change a lot of the days. But if they come early, then fewer and fewer women have to have their dates changed. So I would think perhaps this is a reflection of the very late booking gestation of Harare City clients. But you can prove me wrong. You can prove me wrong by collecting the data and presenting it in a few months' time.
Okay. Yeah, from our findings, the median gestation was 25 weeks. Median gestation at booking.
Yeah, I think it's quite high, and I think Harare City services should have to find a way of bringing it down to 12 weeks from 25 weeks.
Noted.
Through health education and mass media campaigns.
Yeah, sure. I agree with you. I'm sure. Yeah, in one of my slides, in that slide where I was saying that the median gestation at booking was 25, that's where I was saying, how are we going to be able to invert the pyramid of care if median gestation at booking is 25 weeks? So yes, there is a lot of work that needs to be done so that women can book early, so that we invert the pyramid of care. Thank you.
Thank you.
Okay, thank you very much. I see another hand that's raised. Please, may you unmute yourself and ask the question.
Well, thank you very much, Madam Chair. Okay, mine is both a comment and a question again to Dr. Madembo. I just want to applaud him for the good work they are doing at the primary the healthcare facilities. My question is, of the 6 patients referred to the fetal medicine unit, I'm not sure, I'm not clear whether you said they had reversed end diastolic flow for those who had abnormal Dopplers as opposed to absent end diastolic flow. Can you please clarify on that one?
Okay, they had elevated PIs in their umbilical artery Dopplers and reduced, not reversed, it was reduced end diastolic flow.
Okay, thank you.
All right, thank you. We have another hand raised. Please, can you also unmute yourself and ask the question?
Thank you. Dr. Madembo, question for you. You mentioned that up to a third, about 28% of the women that were coming for the ultrasound services that were HIV positive were not on antiretrovirals. The number is quite high, up to a third. What are the strategies to try and reduce it?
Okay, thank you very much. Yes, like what I indicated, those who were not yet on ART, the main reason was they were newly diagnosed. So this was at booking, the initial booking. So they were newly diagnosed, and straight away they will be channeled into the ART program. So they straight away they are initiated on ART. So the main reason why they were not on ART is because they were newly diagnosed. It was during their first ANC visit when they are tested, and people then detect that they are HIV positive. So they were not yet on ART because they were newly diagnosed. But definitely they will be channeled into the ART program so that they are initiated on ART.
Okay, thank you so much. We have another question that's in the okay, we've got another question in the chat box from Dr. Makosa. She's asking, is the late booking a contributing factor to the discrepancy between scan dates and LMP? How accurate is the 2nd or 3rd trimester scan? This, I assume, is directed to Dr. Madembo as well. She's asking, is the late booking a contributing factor to the discrepancy between the scan dates and LMP? How accurate is the 2nd or 3rd trimester scan?
Okay, thank you very much. Yes, that would be a possibility that the late booking as a reason for the discrepancy between the scanning and the LMP given dates. Yes, we know that with increasing gestation, the discrepancy grows. 2 weeks discrepancy in the 2nd trimester, 3 weeks discrepancy in the 3rd trimester. It could be a reason to explain that. Yeah. I hope I've answered that.
Dr. Dube, your hand is raised. I think you can proceed with your question.
Yes, thank you very much. I think mine is just a comment to the question I think that Professor Mjanja actually asked Dr. Madembo. So I think generally women in Zimbabwe are booking quite late. I think their findings are probably similar to something that I found well, in 2018, when I did my dissertation for my subspecialization, where we looked at 2,100 women, we are actually coming to deliver at Mpilo. Well, the results, the dissertation was not published yet, is not published yet. But what we found at Mpilo is that quite a number of our women were, the median age for booking was actually 21 weeks, even at Mpilo, and 8% of these 2,100 women were actually unbooked. So it is quite a high figure, and I agree with Professor Mjanja that we certainly need to bring these numbers down. So to Dr. Mademo, your results actually quite mirror something that I found in 2018. So I may probably have to go back to the institution again, and maybe we do another one and see whether that has changed over the past couple of years. But I don't think it has. Thank you. So there's quite a lot of work that I think we still need to do as a country and as a nation for this tool to come down, so that even ultrasonography will start to make sense in our settings. Thanks a lot for that very beautiful presentation. Thank you.
Thank you very much, Dr. Dube. I see another hand raised. Dr. Verenga, please may you unmute and proceed with your question.
Thank you so much, Dr. Yes, I wanted to comment, Dr. Madembo, say thank you so much, Dr. Madembo. Well done. And I think what you have done is a testimony that if somebody has a passion for a subject, they can go on and be very good and very knowledgeable in the subject and do it very well. To the audience, I think Dr. Madembo and his team, they received a one-week course which we conducted together with the Ministry of Health, an obstetric ultrasound scan course for the district hospital and also primary health centers. And to imagine the amount of work and the way they have improved themselves is a true testimony to say, if you set your mind to do things, you can become good. So I want to encourage people who have passion in their area to say, please go for it and improve yourself until you are very good at it. I'm happy that guys from the ministry are here, from the Ministry of Health, especially the reproductive, the family health department, probably they've joined in. I think we need to lower down the gestational age of booking. That's what Dr. Madembo's presentation is telling us, that we need to lower it down. I know we were saying 16 weeks, and in some of our national strategies, we're aiming for a scan around 24 weeks. But I want to suggest that we lower it even down, even if we can tell women that they have to book their pregnancy the moment they miss a period. I think this is where we need to start. If we do that, we're going to clear most of the obstetric challenges that we face today, because poorly dated pregnancy is likely to be poorly managed. I think that's my comment on the presentation. Thank you.
Thank you very much, Dr. Verenga. Continuing with our discussion, we have another hand that's raised. Please may you unmute yourself and ask your question.
Good morning, colleagues. It's Dr. Gondongwe. I don't have a question, but I just want to say to Dr. Verenga, I have noted the contribution on reduction of the gestational age at booking. We'll definitely work on it. Thank you.
Thank you so much for all those contributions and questions. Are there any other questions or comments for our two speakers? We're having some challenges with the third presenter under the fetal medicine section. And we also, our Nyaradzo Life Assurance representative is also not able to join us today. He's got some medical challenges as well. So if there are any more questions and comments, we can continue with our discussion for the time being. I see another hand raised, Dr. Venge. Please, can you unmute yourself and continue with your contribution?
Yes, good morning. Thank you, Madam Chair. Thank you very much, Dr. Madembo, for a wonderful presentation. I just want to follow on the question asked by Dr. Maua concerning the 28% of women who were diagnosed with newly HIV during pregnancy, that I think there's a need for us to also try and look at the gestational age at which these women were diagnosed. Because remember, as a nation and the world in general, we are looking at reducing the risk of mother-to-child transmission to less than 5%. And this figure is also worrying given the 90 targets that we have, and Zimbabwe actually being praised for reaching that 90% of all HIV positive people actually know their status. 90% of them are on ART, and 90% have managed to achieve viral suppression. And then if you go into the National AIDS Council statistics, you also find that they actually say we are at 86, 90, 90. So what efforts are being put to try and increase or to try and test these mothers early on in gestation for the City Council? Thank you.
Okay, I guess it's a comment. If I got you or a recommendation that we have to look at the gestational age at which they were diagnosed, it's okay. I think we can go ahead in doing that analysis. That is stratifying those who are HIV positive with gestational age at diagnosis. Yeah, but as you are aware, ANC is also used as an entry point for the testing. So yes, it's good that we are also capturing them. We are getting them, and they are then enrolled into the ART program. But I'll go ahead and do the analysis of stratifying those who are HIV positive with gestational age at diagnosis.
Okay, thank you so much. I'm not seeing any more hands or questions. Are there any questions for Dr. Dube? Seems as if all the questions are directed to Dr. Madembo. Any comments or contributions for Dr. Dube's presentation? Okay, it seems as if we no longer have any more questions or contributions. Like I've already said, we will no longer be having our third presenter under the fetal medicine section. She's having challenges logging on, and the Nyaradzo Life Assurance Company representative is also having a medical challenge, so he also will not be able to present. I was wondering if the ZSOG president or the Secretary General, I don't know if they are present in the meeting, would they want to, either of them want to do the welcome and opening remarks that we didn't quite manage to do at the beginning? I don't know if either of them are ready. Sorry to catch you unawares. Is there someone from ZSOG that can give us?
Good morning, Chiramba. It's Dr. Mateveke.
Thank you so much, sir.
Yes. Good morning, everyone. Unfortunately, I got a little caught up very early in the morning with an emergency, and I had to come early and ask someone to ask to just continue for now. I think we'd like to welcome all of you to our second quarter scientific meeting, and I've pretty much enjoyed the first two presentations, which is essentially a sign that we are in for really a roller coaster ride the whole of this day from all the presenters that are yet to come. Please let's stay on for the full day meeting and enjoy the presentations that are coming from the presenters who seem to have done quite a great and lots of work in coming up with these presentations. We'd also like to welcome all our partners, what we don't want to call them sponsors, but partners who partnered us today to help make sure that this conference goes through the whole day. It's unfortunate that the Nyalazo guys are not able to join us. Hopefully, maybe later in the day, they may be able to join and fulfill their part in that regard. With those few words, I say welcome to all of you, and please stay on and enjoy the presentations to come. Thank you.
Thank you so much for those welcome remarks. Would there still be any more questions or comments to the two presenters in the fetal medicine section? I'm not seeing any hands or any questions in the chat box. Please do remember, for anyone those who've just recently logged on, there is a registration link in the chat box so that you can register yourself to get accredited the 8 points for the CME. Please don't forget to fill in that registration form from the registration link in the chat box. Since we no longer have any more presenters in this fetal medicine section, I think we can take this time to take our coffee, tea, refreshment, bathroom break. I would need to confirm with the organizers whether we should take the break up until 10:30, or should we take the break for 30 minutes or take the break for 15 minutes as in the program. If maybe one of the organizers can give me an idea of how long should our coffee break be for.
Well, Dr. Lepepe, I'm not sure how far behind we are with our presentations and time. If you can just, how far behind are we?
We are very much ahead. The last two presenters have fallen away. We were not able to get Dr. Ndakurua's presentation, and the Nyalazo Life Assurance representative can no longer join us. So we are a good, 30 minutes ahead.
No, beautiful.
Start at 10:15.
Maybe we can have a 15-minute break so that we just stay ahead of time, because we know sometimes some presentations can go way beyond their time. So we can take a 15-minute break for people to just relax a little, and then they can come back, and then we'll go ahead with the next next section. At least we would have time on our side in case some presentations take too long.
All right. Thank you very much. Thank you very much. So let's take a 15-minute break. My time right now is 9:47. Maybe if we can.
We can say 9:50 and 10:05 we start.
Yes, yes. Can we all come back at 10:05 for the next session, which will be on maternal health, and that'll be chaired by Dr. Muguto. Thank you so much and enjoy your break.
Dr. Lopepe, are you still there, the chair? No.
Yes, I am, Dr. Veren.
Right. So I'm sorry to say I dropped out of the meeting when I wanted to comment on Dr. Dwe's presentation. But I think I was discussing the admin, and we are having a problem of oversubscription. It's not a problem, it's a good thing. I think it is now clear that maybe as ZSOG, we have to expand our account, which is something we have to look at. I think quite a number of people were shut out of the meeting. I think so that we can accommodate presenters, the admin is going to keep the number of participants in the Zoom meeting to a certain limit, and they will not admit after that limit has been reached, so that presenters will be able to come into the meeting and present. We are sorry for that, for those who try to join and they will not be admitted, but please follow the presentation on our YouTube. We are sorry for this inconvenience, and we'll look into better ways to manage this in the future.
Well, Dr. Lerenga, I think you probably need to make this announcement at around 10:05 because we are way ahead of time and we didn't have one presenter and the Nyarazo guys didn't come. We called for a short 15-minute break from 9:50 to 10:05. So we can give you just maybe 5 minutes to make that important announcement when people come back from the break.
Thank you so much, Dr. Matega. I didn't realize because I dropped my network and I couldn't get into the meeting.
Okay, no, I understand. I think it's an important presentation, so maybe the person leading the next session can allow you to just give the important announcement. So I understand the challenge was presenters are not able to join because we're oversubscribed, right?
Exactly, because I couldn't go back into the meeting. It was saying full. So I fear that Dr. Ndagura could have faced that challenge. I've been trying to conduct and I'm failing to get through.
No, I understand. I think we probably need to expand our, our platform on Zoom. Okay, thanks.
Welcome back, guys. Before the chair takes over, let me just make a short announcement to do with the participation in the Zoom platform. Apparently, we are oversubscribed. We are exceeding the 100 capacity. So what will happen is that the ZSOG admin will try to manage the numbers to make sure that the presenters will be able to get into the meeting to present. So some participants may not be admitted into the meeting, but they will be directed to the YouTube channel. Please bear with us. We will increase our capacity in the future to allow everyone the opportunity to participate in the Zoom platform so that they can ask direct questions. Thank you so much. Back to the chair.
Okay. Good morning once again. This is Dr. Muguto. Welcome back to our CME today, and welcome to our second session this morning. I think one of the housekeeping issues that have been highlighted is that there's a link in the chat. Can we just click on it and register so that we can get our CPD points after this meeting? Okay, so we're sorry for the changes that are there. Now we are starting at 5:00. We're supposed to have this session at 10:30. However, I believe all things work together for good. And we just want to welcome our presenters to this second session. Dr. Gondongo was supposed to present later on, but she's the one who is able to do this presentation now. So I'll just briefly introduce her as she comes and prepares to present to us today. So she's an obstetrician and gynecologist who is currently acting Deputy Director of the Reproductive Health and Ministry of Health and Childcare of Zimbabwe. So her presentation today is mainly going to focus on access and utilization of the reproductive, maternal, newborn child and adolescent health services in context of COVID-19 pandemic. So we're going to have a lot to learn today, especially concerning COVID-19. So help me welcome her as she takes on the podium. Dr. Gondongwe, you're on.
Thank you, Doc. Good morning, everyone. So I'm just going to take you through our services during this COVID-19. And may I have the next slide? So the background of my presentation, the first COVID-19 case in Zimbabwe was confirmed on 20 March 2020. First lockdown started at the end of March 2020. Ministry of Health was not adequately prepared for the pandemic, just like everyone else. Uptake and utilization of health services was severely affected in the early days of the pandemic. Next slide. Okay, so on the uptake and utilization of RM and CAH services, there was a marked reduction in the access and utilization of reproductive health and neonatal and child care services in 2020 when compared to the previous years. A sharp drop was witnessed in Q2, and the reduction was possibly due to pre-COVID-19 health system challenges, for example, on human resources, essential equipment, and commodities. It was also due to lockdown travel restrictions. Some facilities were scaling down on routine services to focus more on the COVID-19 response. Fear of infection, contraction at health facilities by the clients, anxiety and fear of infection by the health workers, PPE shortages, mixed messages in the communities of on availability of RM and CAH and nutrition services. So I've just compiled the data on utilization of maternal and newborn health services for Q1 2018 to Q1 2021, and comparing the data so that we see the trend that we have been following during this time. Next slide. So for ANC bookings, that's for the first visit, the bookings dropped by 2% in Q2 2020 when compared to Q2 2019, and by 3% when compared to Q2 2018. The situation improved in Q3 2020, probably due to relaxation of the lockdown restrictions, and it dropped again in Q4 2020. So this has been shown on the next graph, where on the left we have the number of bookings, on the right we have the quarters from 2018 to 2021. Next slide. So for at least 4 ANC visits, it's plunged by 44% between Q2 2019 and Q2 2020. And the numbers were now picking up in Q3 and Q4 2020, though less than those in Q3 and Q4 2019 and 2018. It's shown on the following graph. Institutional deliveries, there was a marked reduction in Q2 and Q3 of 2020 compared to the previous years. And the numbers were picking up in Q4 2020, though less than those in Q4 2019 and 2018. There was actually an increase in the home deliveries. A previous slide. May I have a previous slide on home deliveries? There was actually an increase in home deliveries in 2020. Next slide, Doc. From Q2 when compared to 2018 and 2019. We had more maternal deaths reported in 2020 compared to 2019 and Q2 to Q4 in 2018. 47% of the maternal deaths in 2020 were notified through the paper-based maternal death notification form compared to 55% in 2019. Next slide. Perinatal deaths. There were less perinatal deaths reported for Q2 and Q3 2020 compared to the previous years. There were some challenges with reporting of perinatal deaths in Q2 to Q3 2020. The perinatal deaths reported increased by 70% due to Q1. Sorry about that. Perinatal deaths reported to be increased by 70% between Q1 2020 and Q1 2021. We had some problems on data entry. Next slide. So, sorry about that disturbance. Okay, so on postnatal care, comparing 2018 to 2021, we see that in 2018 Q3, we had a lot of patients that we saw on day one postnatal, and in 2019 we had quite a high number of patients that we saw on day one. In 2020, there was a drop in Q3 due to the COVID-19, and in 2021 we still had low numbers of the patients that we saw on day one postnatal. And postnatal visit on day 3, We still had a high number in 2019, quarter 3, and in 2018, we had a high number in quarter 3 again, and in 2020, the numbers have dropped. Next slide. Next slide, okay. Day 7 postnatal visits. We had quite a lot of patients in 2019 compared to 2018, and we had very low numbers in 2020, and we still have low numbers during quarter 1 for 2021. For 6 weeks visits, we had high numbers in 2019 compared to the other years, and we still have very low numbers in quarter 1, 2021. Next slide. So for family planning, we compared the numbers on IUCD in session for the years 2018 to 2021. We quite had more numbers in 2019, and at the beginning of 2020, we also had high numbers with quite a drop in quarter 2, 2020 because of COVID. And the high numbers that we saw in 2019 was due to advocating for use of IUCD in women and uptake of long-acting reversible contraception. On implants, we quite had a high number in 2019, and 2018 had low numbers because the advocacy for use of long-acting reversible contraception we had not started by that time, but we experienced quite a rise in 2019. Next slide. On short-term methods, we had quite a number, quite high numbers in 2020 because of the lockdown. The short-term methods were readily accessible compared to the other methods. And for permanent methods, we quite had a very low numbers in 2020 because of the lockdown, and this has to be done at health institutions. Next slide. So we had some successes and some challenges during this COVID era. On the successes, some of the things that we were successful in, we developed COVID-19 guidelines in reproductive, maternal, neonatal, child and adolescent health and nutrition. And these guidelines were shared and operational at all levels of care. The PPE situation is improved significantly in all the provinces, and some of the provinces have got PPE up to June next year. Most, if not all, healthcare workers were trained in infection prevention and control and case management. All reproductive and neonatal and adolescent health services are being provided at all levels in all the provinces. Anxiety and fear of infection by health workers seems to have gone down, possibly due to improved availability of PPE and trainings conducted on IPC and case management. And integrated outreaches are being done, and camps to repair and manage women with obstetric fistula have commenced. The challenges and the gaps that we had, staff attrition, we have critical shortage of midwives and doctors. I think we all know that our health professionals are leaving for greener pastures. The maternity waiting homes in some of the provinces, for example, Marshy West, have not been open since lockdown in 2020. And overcrowding in most maternity waiting homes We have challenges with enforcing physical and social distancing. And although we have tried to supply PPEs to most hospitals and health facilities, still shortages of PPE, especially gowns and aprons, is encountered in some of our institutions. Thank you very much.
Thank you so much, Dr. Gondongwe, for such an informative presentation. I believe we've managed to get a clear presentation of what's the impact of COVID-19 on our service delivery in general is maternal and child experts. At this point, like we've already highlighted, we would want you to put your questions in the chat box so that we can do question session after the presenters, all the presenters have presented. Okay, so our next presenter is going to be Dr. Dodo. Let me just check if Dr. Dodo has managed to log in. He has been trying to log in. Dr. Dodo, are you in? Yes, I think he is in, okay.
Yes,
So, okay, so let me introduce our next presenter, who is Dr. E. Dodo, who is a public health specialist with vast knowledge and experience in maternal and child health in public sector at both district and national level. He's a results-based financing specialist who provides consulting services to the World Bank and other institutions. In his previous role as a health specialist for the RBF program in Zimbabwe, he was a key technical lead in the development of health sector investment case in MCH section that looked at extending RBF approaches to the MNCH at provincial as well as central hospitals. So our presenter today is going to give us a talk on adaptive learning in delivering quality of care in maternal and child health services at primary level. What central and provincial hospitals can apply. So Dr. Dodo, you can take over from here.
Thank you very much. So let me start by first of all, giving us an idea of what RBF is and how it works. Then I will delve into some specific case studies. I will focus on one because of our time. And we see how adaptive learning, in other words, when people observe their situation and they do a quick root cause analysis and they brainstorm and they come up with a solution at a local level, which then has got a huge impact on the results that we are concerned about. Okay, so RBF basically is premised around this theory of change. We have got our existing input systems, the things that we ordinarily talk about. We are always talking about our clinics, our mothers waiting homes, motivated human resources. I just heard from the previous speaker talking about demotivated staff, adequate health financing from government, data for decision making. These are the things that should be in place for us to begin to talk of any provision of services to our communities. But even having those in place, at times we do think that the moment there's a clinic and there's a motivated staff and there is everything, then immediately works. But at times, it has been observed that you can have two facilities with the same inputs, but have vast difference in terms of their outputs and their outcomes. That's where RBF comes in. So in RBF, we are going in there to say, we are supporting you as a facility to go an extra mile in converting these inputs into outputs that matter for improved maternal and child health outcomes. So the process itself is that each facility as management or owners, so to say, for a rural setting, for a rural clinic, the owners of a facility is the health center committee, which is made up of community members, of which the nurse in charge of that facility is also a member of that health center committee. So they are offered a contract And in that contract, there is a specifics of what things they must deliver as an institution. For example, the contract could say expected ANC for these facilities is 300. And so if you achieve 300 of expected ANC, we are going to pay you, the facility itself, such and such an amount of money. So the cycle itself is that after they've been offered the contract, they offer the services. And when they offer the services, there is verification of the quality of those services. And I want us to take note of that because that's the major issue that I'm focusing on, the verification of what quality of services did the client receive. And then an invoice is generated and then they are paid the subsidy. And the design of our RBF in Zimbabwe is that they basically use 75% of what they earn in improving of their quality of services. In other words, the facility has to make a decision to say, these are the gaps that we've identified. We've now earned our money. What can we do to further improve our services? And as you may immediately notice, it means that the primary motivation for the health center committee is to have as much earnings as possible for the facility. So our RBF in Zimbabwe has got a focus on quality. So I will just walk you through this focus on quality. There are four basically things here. We have got, I will look at methods of assessing quality in Zimbabwe, the quality checklists, the client satisfaction survey, and continuous quality improvement. So here's what happens. Every quarter for a rural health center, which I'm going to focus on, the regulatory authority and implementation support authority for a rural health center is the district health executive team. And they also have the responsibility to make sure that each rural health center implements its RMNCH and activities in line with guidelines and policies. So they visit each rural health center once every quarter, and they administer a checklist which is available on tablets. And then they go on ahead to do an in-depth analysis of the scores of the various components. And so the components of this checklist, they have got three components. The first one is structural quality. Second one is management quality. And third one is clinical processes. So you can see that it's a recognition that quality is determined by various layers, all which are interdependent. So you look at the structures that are available, you look at how they are managing their facility and how they are managing indicators of interest. You also look at the actual processes. In other words, you look at how they carry out a delivery, how they do an assessment when a woman comes for a fifth ANC conduct. So the scoring, as you can see, is biased towards clinical processes because these are the ones which change significantly over time. Right, so just to give us an idea of clinical process indicators, so they retrospectively review files and registers. This is what has been happening. It's currently under review. In other words, they would take, for example, a register and look at various aspects. Did they take a temperature when it was supposed to be taken? Did they do a BP check when it was supposed to be taken? Did they document it well and everything? They look even at various, where there was an obstetric complication, how was the response as far as the documentation process is concerned? I know immediately someone is thinking, oh, can't people be working on this on the go? Well, that has been observed in some settings, and already the shift now is towards observation. In other words, they use those, I may not use the correct word, but these are the stations where then you ask a nurse to go there and demonstrate how they resuscitate a child, how they resuscitate according to protocols and guidelines. Right, so this is just how then it looks like. For example, looking at 3C1 there, percentage of mothers in the maternity waiting homes monitored for BP, fetal heart rate, and assessed for danger signs daily. So they go in there and they look at what proportion of those, and then they are scoring, and it auto-generates the results. 2C1, there you can see percentage of first ANC bookings in any 1 month in last quarter we had a documented blood pressure, height. So they also score that. So just to give us broad lessons learned when this has been implemented from 2014, this has been implemented, and so there are a lot of lessons that have been gathered over time. At hospital level, sometimes it's a bit difficult to search for files because they have been misplaced. Remember, it's a retrospective evaluation. At clinic level, you might not find specific complications upon which you want to base your assessment. That is why then all this is why there's now been a decision to say let's consider using workstations for assessment instead of prospective evaluations. Then sometimes the quality of the data in the register is incomplete, and sometimes it's not easily readable. There are a number of documenters who we have got doctors' handwritings out there, and so you want to retrospectively assess, but the handwriting is just not possible for you to see what someone was writing about. But so far, when you then compare scores of particular units and facilities with their maternal and child outcomes, maternal and neonatal outcomes, you see that there's some correlation. You can actually see that as they were improving in their scoring, their outcomes were also improving. Right, so the other lessons that have been learned is sometimes this assessment can even enable you to zoom on a particular staff member to see that this one consistently has got this challenge from the records. And so mentorship becomes targeted based on this. Like I have mentioned already, there's been need to explore additional ways of assessing quality, direct observation, simulation, vignettes, standardized patients. And then of course, there are tracer indicators that should be assessed every quarter to see that this is a particular indicator which we must periodically track over time so that we see change over time. Okay, so I think let me jump out of this presentation and go to the next one so that I share the case study. Okay. Sorry, just a moment. Okay. Okay, so this is a case study from Manicaland that was done by one of the officers working in that province, looking at infrastructural developments at Dora Clinic, Mutare Rural, which had an impact on utilizing of delivery services. So this is basically the basic demographics, catchment population 7,560. It's your usual medium volume primary care facility with women of childbearing age 1.6. Their expected pregnancy is 257. So this clinic is about 30 kilometers to Mutare. And before introduction of RBF services, where there was removal of user fees for maternal and neonatal and child health services, there was an influx of clients coming to the clinic. So basically, you had clients from Mutare, where they are supposed to pay for their bookings, flocking to this clinic, which is 30 kilometers, so you just pay $2 to and fro. And they get their ANC. However, it was observed then at that clinic that there were few deliveries. You had huge ANC, but few deliveries. So this particular this particular story is focused on a woman aged 38 years who delivered a second child in 2011 and third child in 2015. So it's like seeing how the changes that took place at this clinic actually affected your decisions and eventually your outcomes. So what then happens is at the facility level, because of the level of ownership which they have now, that health center committee, which is made up of ordinary community members, they sit down every quarter to discuss what's happening at our clinics. So they then realized that, oh, when it comes to delivery, our pregnant women are bypassing that clinic, which is Dora, and going to Mutare for their delivery, but they would have been attending ANC at this clinic. Then they further inquired to find out what was happening. So they would also even talk to the women themselves. And remember, this is what is happening at a local level. It's not like some team from head office or from the district or even from the province has gone there to evaluate. No, this is the local team made up of community members, which is brainstorming on what issues are affecting them. So they checked and they realized that simple things, not necessarily medicines, but the supportive commodities and facilities, water. There was a problem if you were to stay at that mother's waiting home, water was very far away, so you needed to go and fetch it very far away. Issues with lighting. People were supposed to bring their own lighting, their own candles, their own bedding, their own food, and then of course the other things, medical equipment, which were beyond the community. So these were affecting the woman's decision to utilize that service and deliver at that clinic. So after and also because, so RBF has got indicators which are priced differently, and a delivery has always been priced a little bit higher than other, for example, at that point in time, a delivery was $12. And so for every woman that delivers at that clinic, they would be paid $12. This is an ordinary uncomplicated delivery. So they realized that their earnings were poor because in principle, their cash cow was a successful delivery, and here they were having to lose funds because people come for ANC, then they go to deliver elsewhere. So they then prioritized to say, our women are not willing to stay at our waiting home because of the issues that I have already pointed out. They have to carry cooking utensils. Their immediate environment itself was not very comfortable. And after doing this, they then included in their 2013 operational plan, they said, you know what, let's resuscitate the water supply to the clinic because our bore is defunct. And I want you to notice that this is a decision that is being made at a local level, and they are making it because they have got some funds which they have earned, which is in their power to actually utilize to improve what they have at that level. So this is just some kind of chart showing how deliveries significantly improved from 2013 particularly, going on to 2014, 2015 there, when this intervention took place. So let's zoom in on Miss X that I talked about, because sometimes when you are speaking of adaptive learning, you want to hear the succinct emotional components of what was happening. So this lady delivered a second child in May 2011 at this clinic, and this is your experience from your own mouth. So it was a difficult period for me as my husband had been laid off at his workplace and we moved to the rural home. The nurses encouraged me to come to the waiting home, but I could not because it needed someone to stay with me at the home to assist with fetching firewood, water, and assisting me in labor. The little food and blankets in my home could not be shared between me and other family members remaining at home. I was expected to bring 2 candles and cotton wool to the labor ward. So I had to go when labor had already started and delivered my baby. And after delivering, I had to wait for my husband to come and fetch water for me from the bore about 500 meters away. He also brought me food as there was no food at the clinic. The nurse had given me tea and bread from your home though. Now you can imagine then what the nurses at this frontline level have had to do because of that scenario. Now we come to an experience with babe number 3 delivered in 2015. I attended ANC at Dora Clinic, and one of the health education talks, we were encouraged to wait in the maternal home for 8 months of pregnancy. We were taken on a tour of the delivery facility. I was happy that the clinic had electricity and piped water. The waiting home is now an electric stove, and we were given food rations that we cooked as a group. Beds and bedding was available. I was not scared to sleep at night as a guard was always making runs around the clinic. There was even a football for exercises. Upon delivery, I could bath with running water, wash my clothes, and food was available for the 2 days that I stayed at the clinic. All my needs were met and I was very happy. I now urge all my friends and relatives to use the services at Dora Clinic. I think the contrast is very clear there. So what happened between 2011 and 2015? Dora Clinic went on a plan to make sure that there's food available. They included this in their operational plans, which means they were able to procure food, and this food is being procured in the local vicinity, further improving the local economy. And the point number 4, the women really understood that referral at next level was based on risk rather than lack of essential commodities. The last point is my point of emphasis: making mothers comfortable led to improvement in uptake of deliverance at this clinic. It was no longer an issue of whether the nurse is able to deliver or not, but it was because of a very comfortable setting. So just to show some pictures here, this is on your left there, the staff members. This is the broken down bowl, which was not functional. This is now the new setup. This is the waiting mother's home with the beds there, nicely done, mosquito nets. There's a stove there where they can fix their meals. Of course, this is now, you can see that even the health workers themselves, they then become motivated. This is now the ward itself. Yeah, so this is the story of this woman. But what we see here is putting funds at point of service delivery promotes innovative approaches at that level, which are responsive to the unique issues that they face. I would want just to finish with some thoughts that have gone into trying to see how this might be considered for adaptation at provincial and central level, because this has been mostly at primary level. So at this level, what is important from the MPDSR reports and from the high institutional mortality and the challenges with the referral pathway, there is need to have an RBF system that assesses, that pays subsidies at central and provincial levels based on technical quality of care. So the quality checklists have to be developed by organizations such as ZSOG, where there is that neutrality. So I think bringing together this and the pediatricians and the anesthetists and all that, and then they develop this checklist, which is technical. And then every quarter, there's engagement of a technical team, which is seconded from the MPDSR committee, which goes to assess the performance of each central hospital or provincial hospital against the pre-agreed technical areas. And of course, just like what happens in rural settings, we also must get the perspective of the users. We often then hear from the news that a nurse from such and such a provincial hospital was complaining. We then need to have a robust mechanism of ensuring that through either exit interviews, I think for a central hospital or a provincial hospital, an exit interview mechanism would best work, which looks at their user experience, not from the perspective, from their perception and how their experience made them feel. But before this happens, like I mentioned right at the beginning, if some input systems are out of place, you surely can't expect miracles to be performed by the frontline health workers. And so the starting point of this is a primary investment into each central hospital and each provincial hospital based on a pre-agreed assessment criteria of the basic package needed for them to offer the kind of services that they are supposed to offer. And that has already been sent out there to some donors to take a look at, and I think it's work in progress. Is Dr. Nyat in the house? We were supposed to then jointly present that rep sit up.
Hey, Doc, I'm here. Good morning, colleagues.
Okay, good. So I will stop sharing. Over to you, Dr. Nyat.
Thank you very much. Good morning, colleagues. I think Dr. Dodo has pretty much shared it. Apologies for joining in late. I was trying to multitask. But essentially, what happens is at Codate, we give technical assistance to the Ministry of Health and Childcare to develop their capacity to improve several aspects of the health systems, including improving quality of care through an integrated national quality assurance and quality improvement. We actually contract health facilities to implement innovative strategies that increase access and utilization of healthcare. We want to promote the RPF through sustainability, through institutionalization of critical functions. And what has happened was currently there's a grant, I think, that was given. The Ministry of Health, the government of Zimbabwe received a grant, I think, from the World Bank. Of course, there's co-financing between the ministry and the government of Zimbabwe, where one of the components is actually introducing RPF in central hospitals and reconfiguring RPF in a phased manner so that there's improved quality of services in order to reduce the case fatality rates for perinatal health. So I think Dr. Dodo did, I'm not sure I joined late, but I think he did tell you that in RPF, essentially there's the predetermined, or we agree on the services that we are going to be offering, and there is a cost. I think there's a subsidy that is given at the end of the quarter after the results have been verified. So the subsidies that are actually given essentially are meant to improve the level of the environmental the health environment, so that at least the tools of the trade, the people that are working are able to have what they need in order to deliver services. And part of that subsidy, if quality of services is deemed to be appropriate, part of those subsidies actually go in as incentives that are given in for health care workers to actually take into their own pockets. So as you might have mentioned, this is going to be piloted. I think discussions are currently ongoing between the policy, the family health department, the program coordination unit to actually introduce possibly maybe a cadre who will be a doctor who will be able to look after, or rather to be the coordinator of this process. So essentially, what we're trying to do is, I think the aim is to sensitize you about the RPF being present in already in rural facilities and now coming into the central hospitals as well as the provincial hospitals, and to a certain extent to also be able to consult. I think you are the obstetricians, you are the specialists, to be able to consult as to what you would think would be the proper design or the effective design of the RPF project when you are developing the quality checklist, and so that you actually have improved outcomes for the patients and those that are accessing health services at our central as well as provincial hospitals. So I think I'll just stop there. I think if there are any specific questions. Thank you. Over.
Thank you so much, Dr. Nyati. Thank you so much. Unfortunately, we couldn't introduce you. You kind of just continued on. Maybe I could briefly introduce you to our health personnel who are here. Dr. Nyati is a public health practitioner who is currently in health financing and health systems strengthening, and is based in Ministry of Health and Child Care head office. So thank you so much for such a presentation. Thank you so much, Dr. Dodo, for such a motivating presentation, which clearly shows a significant change for the better, a positive impact on change, which was initiated mainly by the health providers. That is taking, I'm talking about the case presentation that you presented. It's a refreshment in our environment where we have got lots of negatives that are happening. So thank you so much for such a powerful presentation. Maybe I can quickly read through some of the comments. We won't do questions now, but I'll just read through some of the comments that have been put across by our participants from Dr. Munjanja. Congratulations, Dr. Dodo. From Dr. Bosuman, excellent work. washing machine at Rural Health Center. That's something amazing. And also Dr. Mavetera, thank you, Dr. Dodo, for such high quality presentation, which is low cost but high impact strategy. This empowers community to take care and make relevant decisions at local level, and community can do M&E at local level. Excellent stuff. And also Dr. Choto Regis, very insightful and good practical models to improve service delivery. Such models would be good for fully governed, government-supported initiatives using national fiscus rather than donor funding. Very difficult to get donors to support such initiatives. Who in most situations do not advance their funding, but rather pay for services that have been rendered. The other challenge is on choice of indicators to track which tends to be a process based on non-standardized across districts and facilities. So thank you so much for such an amazing presentation. We'll go through the questions that have been highlighted, but we'll go to our next presenter, who will be our last presenter for the second session. This is Dr. S. Gororo, who is a consultant in Obs and Gyne, based at Gwanda Provincial Hospital. He finished his FCOG in 2018, and his subspecialty interest is in urogynecology. So today he's going to give us a presentation on obstetric practice in the province, focusing on impact on maternal health services delivery for Mat South Province. So Dr. Gororo, you can take us from now.
Thank you very much, Dr. Mkuto. Let me just try to share my screen here. Can you hear me, Doc?
Yes, we can hear you clearly.
Dr. Mkuto, can you hear?
Yes, you
okay,
are clear, Doc. You can go.
Okay, I'm trying to share my screen here. Okay. Just a moment, Doc. I think I have issues with sharing my screen here. Essentially, what I'm going to present on why I will probably try to share my screen for the sake of time. It's a presentation entitled Obstetric Practice at Provincial Level. Are we making an impact? So in general, my presentation intends to probably highlight the work that we are doing in Mat South Province, and assess if we are probably making a difference by being a specialist outside the central hospitals and being in the province. Just give me a moment, Dr. Mkuto. I think I have issues with the screen here. Okay, can you see my screen, Doc?
Yes, we can see your screen, Doc. You can go ahead.
Okay, thank you very much. Okay, so yeah, that's the title of my presentation, Obstetric Practice in the Province, Impact on Maternal Health Service Delivery for Mat South Province. So the outline of my presentation is such that I'm going to give a background, then look at obstetric practice in Mat South Province, the levels of care for pregnant women, our goals as a province, a bit of statistics on maternal deaths, and to share some success stories that we have had, the challenges as well as the possible recommendations that we can probably put across. So in terms of background, this is where Mat South Province is on the map of Zimbabwe. This is where Mat South Province is. And it's a province that consists mainly of rural districts with few towns. Actually, there are only probably 3 towns within the province in Beitbridge district, Gwanda district, as well as Mulimamango, where we have Pantry. The rest are essentially rural districts. We have a total of 7 districts, The overall population of the province is around 683,000, and slightly more than half of that population are females. And we have 6 district hospitals within the province, 4 mission hospitals, then rural clinics and urban clinics. There are only 3 urban clinics within the entire province. Now, in terms of probably where do I fit in as an obstetrician within the province? Myself, I joined the province in 2019 after completing senior registrar. I report to the provincial medical director, and at provincial level, I mainly interact with the provincial maternal and child health officer and reproductive health officer. So this is essentially the team that I work with in terms of organizing programs at provincial level. So the levels of care for pregnant women within the province is structured in such a way that we have rural and urban clinics at the base, which then refers clients that need probably referral to the district and the mission hospitals. The district and mission hospitals in turn refer to the province, which is under provincial hospital, which then refer to United Bulawayo hospitals. But often, because of issues of proximity, we have clinics that also refer directly to provincial hospital. We have clinics that also refer directly to United Bulawayo Hospital, particularly clinics in Caesar district and part of Matobo. And we also have district and mission hospital that also refers directly to United Bulawayo Hospital because of the issue of proximity as well. Out of the 7 districts, 3 districts refer to the provincial hospital, while the other 4 refers directly to United Bulawayo Hospital. So what have been our goals within the province in terms of maternal health service delivery? So through the PMD, our main aim actually is to eliminate maternal deaths, to reduce maternal morbidity, as well as reducing referrals to central hospitals. Now that we have a specialist within the province, we aim to reduce the number of cases that we refer to central hospital. But in doing that, at the same time, we don't want to compromise the quality of care that we are offering to pregnant women. Our aim is as well is improving the level of knowledge and skills at all levels of care within the province. I would probably emphasize this last bullet, why it is important that knowledge and skill is disseminated in all levels of care. One of the things that you see probably if you are from a central hospital, rarely do we have maternal mortality from a case that was looked at a central hospital. In most of the cases, the bad outcomes that happens in central hospital is because a patient came from the district, and oftentimes from district the patient will have started at local clinic, at a rural clinic. So oftentimes, if you don't improve the quality of care at the level of the local clinic, there are going to be more bad outcomes at provincial level and at central hospital. So the more the level of knowledge, the more the level of skill is disseminated to grassroots level, the better the outcome we have at higher levels of care throughout the system. So how have we been probably trying to achieve this? Our main thrust since I joined the province in December 2019 is support and supervision or mentorship. This is essentially where as a team we visit the provincial, the district hospital, we visit the clinics to impart skills and knowledge, and in general to assess how they are working, to have a clear understanding of the environment within which they are working. So when we visit the clinics, it's essentially through the basic emergency obstetric newborn care support, whereas at the district and mission hospitals, we are looking at the comprehensive emergency obstetric care skills training and support. So the benefits that you realize we derive from this going away from the provincial hospital where we are stationed to the grassroots level, to the clinics, to the districts is, number one, there's going to be an improvement in terms of professional and social relationships that exist between the consultants and the GMOs, the midwives, the nurses at a district hospital or at a clinic. And often it is the establishment of this level of relationship that help to kind of flatten the hierarchy so that it becomes easy for a GMO who is in a district hospital that is probably 300 kilometers away to comfortably wake you up at 2 a.m. at night and ask for assistance, asking for your opinion and consult. Often because of sometimes the relationship that exists in central hospital between the SRIMOs and the consultant, there is a gap that is probably breached by the junior registrars and senior registrars, so that the interaction for them to consult is not that easy. But when you go down and interact with the GMOs at district level, you are kind of closing that gap and removing that probable issues of fear to consult, fears to call you and ask for assistance. Even nurses at a rural clinic, when we do these visits, we leave their phone numbers there. They are comfortable of calling you and asking for assistance. And by doing that, oftentimes there is prompt delivery of the appropriate service. Another benefit as well is sharing of skills and knowledge, improved understanding of the strength and the limitations of the environment within which the cadres out there are working. This is actually quite important because oftentimes when you give your views and opinions to a GMO or to a nurse who is asking for an assistance, it is important to understand the background within which they are working, because often that tailors the kind of recommendation that you are going to give. So you may realize that you can have a similar case at one hospital, but probably the recommendation that you give is different from what you give to another GMO who is at a different hospital because of the differences in their environment. So this is just an image showing one of the occasions at one of our district hospital when I was actually scrubbed with a GMO. We was operating a patient with 3 previous cesarean sections. So you realize that some of these cases, there were cases that GMOs prior to our visits, they were not probably comfortable of doing alone, or cases of repeat cesarean sections were being referred to either provincial hospital or central hospital. But when you impart these skills to them, oftentimes they become comfortable of doing some things on their own, which in turn then help in terms of delivery of service. Also at the provincial hospital, we conduct consultant-led antenatal clinics. And in this, most districts refer clients that probably would require specialist service, but often because of the rural background, they are not able to travel every time to receive antenatal care. So they often come at our clinic probably once or twice during the course of the antenatal care. You see them, you write a plan probably of what should be done in subsequent visits when they go back to their to the district hospital from which they would have referred. And the GMOs there, they have a clear outline that you've outlined for them that they will follow. And each time that happening within every district. So at each time, you clearly have an idea of what's happening at each district, what are the challenges that are faced, what are the challenges that they are facing, what are the possible complications that they've experienced, and oftentimes you take them through managing some of those complications. So probably a question that I would like to pose at this time is in terms of what we are doing. So I will not answer that question at this point, but probably give some more slides, probably see whether what we are doing is making a difference. So I'm on maternal deaths that we've experienced in Mad South Province, comparing the year 2019, 2020, and then the first half of 2021. So probably we may put an argument forward that it may be too early to see a clear picture of benefit, but probably this may give us a highlight of the trend towards which we are going. So as a province, in the first half of the year 2019, before I joined the province, we had a total of 7 maternal deaths throughout the province in the first half. Then came the first half of 2020. 2020 was not a good year for almost most institutions, and I think probably this is the kind of statistics that a lot of institutions may reflect because of the impact of COVID-19. We had 13 maternal deaths within the first half of the year. Most of these issues we attribute to the impact of COVID, the confusion that existed when COVID came in. Often in some places there was closure of antenatal clinics, maternity services became very skeletal, and often access to health facility became very poor for the majority of our clients because of the issues of lockdown. But I guess with the course of COVID, we have kind of learned to adapt and probably cohabit together with COVID. So this is what then has happened in 2021, the first half of 2021, with 5 maternal deaths. We can clearly see that there's probably an improvement. We'll see as the year goes, but our aim is to continue putting on the thrust so that we kind of reduce or totally eliminate issues of maternal death as we go to the second half of 2021. And probably just to also give an indication of what has been happening at Gwanda Provincial Hospital, where I'm stationed. 2019, in the first half, there were 3 maternal deaths in the first half of 2019. 2020, we had again 3 maternal deaths. Now in 2021, in the first half of the year, there's only 1 case of maternal death. Of course, that 1 case is not good, but we have kind of experienced some reduction in the number of cases of maternal deaths. And this death that we had, this was a patient with postpartum hemorrhage at a district level who was then referred to us. And by that time, we had no blood at the institution, so was essentially transferring to United Flower Hospital, and then she passed on in transit. So this can give us a clear, a kind of an idea of the trends that we are moving towards. Then we also have some success stories probably to share in terms of the impact that probably we can say we have managed to derive from the presence of a specialist within the province, and also the work that we are doing in terms of support and supervision, in terms of mentorship. We have had a number of cases actually that a GMO, because you have a case of, for example, a ruptured ectopic pregnancy at one point. They don't have fuel to transport the patient. So clearly the patient had to be operated at that level. The GMO has never done an ectopic pregnancy before. And by consulting, you kind of reduce the fear that existed in here to perform the operation. And you tell a clearly document that I've consulted Dr. Kororo on this case, and you told me to go ahead with the operation. Because oftentimes the fears that the cadres down there here is if the patient has a bad outcome, if the patient died while I'm trying to operate the patient, probably I'm going to receive some disciplinary measures of some sort. And oftentimes that then hinders the delivery of the necessary service. So often by the doctor consulting you and documenting that I consulted our provincial specialist, often that removes that fear. So the doctor called the case of ruptured ectopic pregnancy. They went to theater, the video called while they were in theater. We instructed them over video call. They successfully managed to perform the ectopic pregnancy. They transfused the 2 minutes that they had at the institution. The patient didn't need to be transferred. And often those cases boost their confidence, boost their morals. The next time that she had another case of an ectopic pregnancy, she just informed me of an ectopic pregnancy. She went in theater, the cases went well. So these are some of the little successes that we probably have. So you may realize that probably our successes are not that we have managed to do an unheard of kind of surgery, laparoscopic cesarean section, that kind of unheard of things, but it's the simple, small things that we are able to implement at grassroots level, but probably that will make a difference in terms of reducing mortality. When I first arrived in the province, there was quite a huge number of cases that were being referred both to the central hospital and to the provincial hospital. And you do the repeat cesarean sections with them. They actually do the case while you assist them. They do the case on their own while you watch. Often it just boosts their confidence that they are able to handle these cases. And the next time that they receive probably a patient with previous cesarean section is in advanced labor, that probably may be at risk of rupturing if they even attempt to refer the patient. They are comfortable of taking that patient to theater. And we've seen quite an increase in those cases, and most of them with good successes. GMOs becoming comfortable even operating a clamped patient at district level, and oftentimes being able to actually retain the patient at their institution without need to refer them. At Rwanda Provincial Hospital, where I'm stationed, I work with a team of GMOs that are fully attached to maternity, and they are now able to perform subtotal hysterectomies, even proper hysterectomies. Of course, they don't do on their own when we are doing a guide list, but subtotal hysterectomies in cases of emergency, and I'm not available. We have had a number that we're able to perform. In one of the cases, actually, we received a patient with a ruptured uterus from clinic, and obviously to transfer that patient to United Blawayo Hospital, because I was absent at the station, was not going to be possible. The patient was going to demise in transit. The GMO opened, managed to do a subtotal hysterectomy on a patient with ruptured uterus. We then transferred the patient for transfusion because we didn't get blood. So those are some of the successes that you could see. They are simple things, but probably making a difference within the province in terms of reducing mortality. At one point, in one of our very remote district hospital, there was no doctor at that time at that district hospital. There was only a clinical officer. She received a patient with a grand multiparous patient who had ruptured the uterus, attempting probably to do a home delivery. And she could clearly pick that most likely this is a ruptured uterus. When she assessed the patient, she wanted to refer the patient, but again, there was an issue of fuel, so which probably hinders them to transfer the patient in time. And I take her through how to apply a tourniquet. She took the patient to theater, managed to open, apply a Foley's catheterized tourniquet on the uterus, and arrested the bleeding, then transferred the patient. Because of the impact of that tourniquet that she successfully managed to apply. The patient, we managed actually the patient when she arrived at the provincial hospital, which probably that tourniquet was a lifesaver for that patient. And oftentimes, when they manage to do such things, you then call them back and compliment them that they've done well. And often it's those small compliments actually that boost their morale, that boost their confidence. At one point, after we've just done a BMOC support, a sister, a PCN at a rural clinic, phoned, she had a patient, postpartum hemorrhage, non-responsive to teratonics, has tried a lot of things that were not working. And we just recommend what we have taught, apply a uterine tamponade, a balloon catheter. She successfully managed to do that. The bleeding stopped. When the ambulance arrived, they could transfer the patient. And by the time the patient arrived at district level, the patient was still in a state that the doctor could successfully manage. So you see, those are some of the little successes that could be done at the very, very basic level of care, but making an impact in terms of reducing bad outcomes. And we feel that because of that, there could probably a reduction as well if such levels of implementation are done at every level of care. You could see a reduction even in terms of mortality at hospitals. And at Gwena Provincial Hospital, we actually managed to also reduce the number of referrals to United Blower Hospital. When you compare our statistics, 2019 and 2021, we have seen that we have a 90% reduction in the number of referrals. And most of the time that we refer a patient from the provincial hospital to UBH is because the patient might need ICU or the patient needs transfusion and we don't have blood. However, despite these successes, we also have our portion of challenges, which range from unavailability of equipment, oftentimes to do investigations. So because of the nature of the population that we cater for, which is mostly rural, oftentimes you don't have that window to probably do fence investigations and ask the patients to come back, because in most cases, if you don't implement what you feel is right, you may not see that patient again. Oftentimes, we have challenges of patients that have been referred from clinics to the district, but they don't show up until the day of delivery, only to present two previous Caesar presenting in labor. So those are some of the challenges that we may need to adjust our model of care so that it fits our population. Issues of poor road networks. We have some districts, some rural clinics that are in far to reach places, often making it very, very difficult for them to be able to transfer time. Poor network services.
Sorry, Dr. Gororo, sorry to interject. Just to notify you because of our time, you just left with about 5 minutes. Sorry to interrupt.
Okay,
Thank you.
No. District, for example, in Bridge, we have some clinics that actually are in areas where we don't even have the Zimbabwean networks, cellular networks. It's the daytime, so she can go to the mountain there to make a phone call. So those are some of the issues that then affect issues of ambulance that are broken and not being able to probably transfer the patient, the massive exodus of staff. We literally working with a skeletal staff within the province. We have some hospitals, districts, and particularly mission hospitals that are actually operating without a doctor at all. in some with probably one or no midwives at home. And then unavailability of blood products or limited availability. And then other challenges that probably I face myself as an obstetrician at provincial hospital is unavailability of complementary specialties and so forth. The issues of unavailability of a pediatrician. Often it makes decision making very difficult, and often you may end up transferring a patient. Not that myself I'm not able to offer appropriate care, but you are now considering if you deliver this neonate, this baby, are we then able to offer appropriate pediatric care at a district hospital? And as well, one of the greatest challenges that we are facing these days is unavailability of fuel. Hospitals to be able to transit these days is taking which often is not available to buy the fuel so that we are able to. So RBA funding that most institutions services. Probably if you can have some sort of to retain staff, probably a provincial branch of blood products. We need a new equipment within the province. Most district hospitals have anesthetic machines that are broken down or are poorly functioning. Off-road vehicles for the provincial specialist. Oftentimes it may be faster in cases where there is an emergency for the specialist to actually drive to the district hospital than for them to send the patient to the provincial hospital. And often that is not possible if you don't have an off-road vehicle. Then I cannot overemphasize the need for accessible fuel for our ambulances. My greatest acknowledgement goes to our PMT for the great support that she's giving us. I cannot overemphasize the support that we receive as a province from the obstetric department at United Bulawayo Hospital, and also to thank ZSOG for this opportunity to present. So I believe we are making a difference in South Province. Thank you.
Thank you so much, Dr. Gororo, for such an amazing presentation. Thank you so much for all the testimonies that you have put across and you have shared with us. I think this is evidence that if we go an extra mile, if we empower others, those are maybe following behind us. If we do the maximum that we can do, a lot can be done and we can achieve a lot even with minimal funding. Thank you so much for such a presentation. And I think you can go through the chat comments. There are lots of comments for you to go through. We want to go through those. So he was our last presenter for the session. So we'll go through some of the questions. I think we've got very few questions and lots of comments, meaning the presenters were doing a good job. So we'll just go through one of the questions that was highlighted in the chat box. I think this was directed to Dr. Gondongwe. I hope she's still on. The question is, how many of our pregnant women has had COVID-19 that delivered during this period of 15-month period of COVID-19, and what has been the outcomes and the quality of service or care that was given to them? So Dr. Gondongwe, please, if you're still on, may you take up this question for us. Dr. Gondongwe? I think she's no longer on line. I think she's no longer online. Any more questions for the other presenters? We have got Dr. Gororo still online, and Dr. Dodo was still online, and Dr. Nyati. Okay, there's a hand up. I think Dr. Munjanja.
Thank you, Chairperson.
You can go ahead, yes.
Thank you. Yes, well done to all the presenters. And I really liked the improvements that were made on the mothers waiting shelters in the example given by Dr. Dodo. Thank you very much for that. For Dr. Gororo, I also wish him well in his work, and I'm very impressed by the achievements that he and his team have made. Just a small refinement regarding counting maternal deaths. I think for the sake of completeness, the RHO and the PIMCHO should visit the district registrar general's offices. The registrar general's offices record maternal deaths among women who have not passed through the health system. And so we are now recommending that district authorities visit at least once a month the district registrar's offices or the provincial registrar's offices, where they will be shown a book which has got the BD10 and the BD11 and BD12 records. Those who will not have passed through the health system won't have a BD12, I think. But they will find a few more deaths which have not passed through the health system. So we have some information about Mantobo that I can share with him later. An exercise that we did last month or the month before. So I think you will find a few more deaths. Also, the deaths which occur at UBH from the districts and from Gwanda should be recorded under the districts of origin and the province of origin. Later in the year, I'm going to come around with the team from the Ministry of Health when we are going to report the maternal death ratios of 2018 to 2019 nationally. And we are doing an exercise in which we are going to all the provinces and we are going to talk about this. So you'll hear more about it, Dr. Gororo. But thank you for the wonderful presentation and keep up the good work. Thank you.
Thank you so much, Dr. Mjanja, for that comment. Okay, we still have Dr. Gondongwe's question. I'm not sure if anyone from the floor could give us statistics on the number of women who were pregnant during this 15-month period where COVID-19 has been with us, and the services that they were given and the outcomes on their deliveries, and or maybe the outcome in general. If anyone from the floor could assist us with any comments on that. Okay, we have a hand. You can go ahead and comment or question. Dr. Sisimai.
Thank you very much, Chair. My name is Chenjerai Sisimai. I'm a member of the health team from the World Bank. And thank you very much for also extending this invitation for us to also participate. Thank you to the presenters again, very clear presentations, and it's really good to be sharing these lessons over time. It's just a few remarks relating to the presentation from Dr. Dodo and Dr. Nyati relating to results-based financing and some of the results we've been witnessing over the years. Just to start off by saying that I think the title itself has been coined well. It has been several years of learning led by the government. And I think from that learning, we are looking at seeing an extension of this going further. And there was a comment in the chat box that was linking to financing from the government. So I just wish to highlight that one of the remarkable aspects of results-based financing in Zimbabwe is that over the years, we've increasingly witnessed the support from government in terms of financing the program itself, starting off having had support from external partners, continuing with external partners, but right now we are seeing this commitment towards institutionalizing this approach. And I think this would really further strengthen the agenda of making this a health system strengthening tool. In itself, it is not a silver bullet, but it really comes in on board to complement all the efforts that are happening within the sector. And I think it is a very important aspect. The second comment relates to the quality focus. When RBF started, indeed, there was a quality element, but one of the key lessons that was picked up was the need to focus on quality. Despite the improvements in coverage, quality was slackening, and we see that right now all these initiatives, the quality checklist and how it is being applied really comes in on that point. But I think one consideration to take into account for the team is the development with regards to the electronic health records. I think there are some opportunities that are coming there where we could actually integrate elements for continuously assessing quality and facilitating the learning and improvements at the facility level. And I think it's something that will need to be considered. But thank you, Dr. Dodo, for also highlighting the role that ZSOG might actually have in shaping how RBF can actually be implemented at the higher levels, at the hospital levels, because it is slightly different from what had been implemented at the primary care level. And I think it's an opportunity that might need to be taken forward. So a big thanks to also the other presenters. I'll stop there for now. Thank you again.
Thank you so much. Thank you so much. I don't see any more hands or questions. So I think we can say this is the end of our session 2. Thank you so much for participating. Okay, please.
Can I ask Dr. Dodo?
Okay. You can go ahead, Dr. Mjanja.
Can I ask Dr. Dodo or Dr. Nyati? I can't remember which of them made this point about the central hospitals, the RBF exercise being extended to the central hospitals. I want to ask, where will the funds go if they come from the World Bank? Will they go into the central hospital account or into an account dedicated for the maternity services? And the reason I'm saying this is that for several years at Harare Hospital, I tried to make sure that the money which was dedicated to, or which was being generated from maternity, went back into maternity for improving the services. All the central hospitals used maternity earnings to improve the other parts of the institution. So women, even when they were paying user fees, they would pay the user fees, but nothing would change much in maternity, but the money went to psychiatry, medical wards. I'm not saying those places don't deserve these funds, but there's some unfairness when money has been raised or through maternity for the benefit to be taken away from maternity. So when you do this, please make sure that there is an account open at a bank for the maternity section, so that the funds don't go into the general hospital account.
Okay, Dr. Dodo, may you approach and tackle that question.
Okay, I will start, and then Dr. Nyati can add anything that he might want.
Bluetooth disconnected. Waiting for connection. Waiting for connection.
So basically, what happens is with RB, all expenditures for RBF are based on a pre-agreed expenditure plan and operational plan. And I think part of shaping up this is the contracting process can determine from, and I think that is already underway,
can determine what proportions are allocated towards what. So yes, that concern is part of the conversation already. And that is why we also have emphasized the importance of such bodies as ZSOG in terms of the necessary lobby at a different level, so that there is an agreement as part of the contract right at the beginning to say such and such a proportion must be directly used into such and such areas. But like I said, a contracting process is linked to two essential elements. Number one, an operational plan. Number two, a procurement plan. So it helps to safeguard and ring-fence the funds so that they go into predetermined areas of investment, which are linked to the agreed output. Dr. Nyati, if you have anything to add.
Thank you very much. Yes, I think you've actually said it, but also to emphasize that I think one of the elements of RRPF is autonomy, where the management level is able to, or is empowered to make decisions according to their own need. So the national level cannot dictate what should be procured using the subsidy funds. But however, the management, I think, when they actually do the contracts, they will, based on their operational plan, what is going to be procured using the subsidies. So I think it is very important to actually, in the operational plan or the procurement plan, play an active role at management level at the central hospitals as well as the provincial hospitals, so that once subsidies are received, they are actually channeled towards what is the priorities according to the plans that would have been made at that level. Thank you. Over.
Thank you.
Thank you so much. I hope you've
If I can
answered,
also
Dr. Njanja. Yes, you can go ahead, Doc.
Okay, thank you. I think it's a very relevant inquiry or question and comment made by Prof. Njanja. I will just add a few things based on my own personal experience as part of the committee that runs one of these funds at one of the central institutions where I'm based. The main challenge is that the money is coming. There is sort of like a separate account, but the main challenge is a lot of red tape, because you find when the money comes from these organizations, its use at the end of the day is guided by the what you call them procurement regulations from the Ministry of Health. And there's actually a lot of red tape, because when you want to use money over a certain limit for an emergency procurement, for instance, then it has to go through, the standard procurement procedures. And sometimes this can take months when you go for tender and the like. And yet in maternity, you actually want to use the money like yesterday. That's the major challenge that we also faced. So I don't know what arrangements can actually be made with the ministry when it comes to easing or release or sort of like softening these requirements. They are key, because they sort of like, avoid a lot of underhand dealings when it comes to use of these monies. But somehow, I think they need to ease these rules when it comes specifically for use of these funds. I don't know what Dr. Dodo can say about that.
Dr. Dodo? Or Dr. Nyati?
Very much for the question. Yes, I think it has been noted that the introduction of the new procurement guidelines has actually led to several bottlenecks. Yes, so there has been, I think, some by the procurement regulatory authority of Zimbabwe actually have called on public organizations who actually use public funds to come and actually discuss and see how some of these bottlenecks can be addressed. So the conversations are, yes, they are they are going on to try and improve the utilization of subsidies, because ultimately the red tape that we actually have alluded to is causing some challenges in utilization of funds, and there are at times where you need to utilize funds quickly, like in emergencies, as you have mentioned. So essentially, I think whenever the communications do come around, please do participate. But those challenges have been noted, and the PRAS is actually taking lead where the I think the Ministry Program Coordination Unit has also participated in trying to modify certain elements or certain sections of the Procurement Act to address those challenges. Thank you.
I will just add to say, when you do, right now, one of the reasons why central government has been very forthcoming in supporting RBF and directly investing funds, government funds into RBF has been because of the expenditure patterns. So for RBF, there's creation of, that is a primary level where I know how it is working. There are temporary deposit accounts that have been created, whose governance system, though while it is subject to the public management finance system, allows some procurement thresholds. They allow procurement even in the locality. So, because the Minister of Finance has seen that when you look at the overall expenditure, even at Ministry of Health, the budgets that have moved most finance and have had a strong link with actual results at the ground have been the RBF budgets. So I think, like Dr. Nyate has said, the ongoing revisions of the Procurement Act provides an opportunity then for ensuring that it also happens at a central level, province and central hospital level. Thank you. Over.
Thank you so much. Thank you so much for your comments. I think we are done with this session. I believe there are no more questions. Thank you so much to all presenters for such amazing presentations, informative and comprehensive. At this point, we will have a representative or a specialist from Mindray who will take us through KDB Healthcare. If they are online, maybe they can take this time to address us.
Hello, everyone. This is the time for Mandarin. Okay, and so I will, first I would very appreciate the organization from ZSOG and also the support from our partners, KDB, and also all the professors and doctors gave a very excellent presentation. And here is Mandarin, and I'm the marketing manager of English speaking area. And I would like to share some solutions, ultrasound solutions from Mandarin. Can you see my screen clear?
Yes, it's clear. You can go ahead.
Okay, yeah, first, okay, first I would like to give some simple information about Mandarin. Now, Mandarin are serving over 190 countries and regions, over 11,000 employees from 3 countries. And also, you can, also you can see that we can provide the one solutions across the hospital, from the OR, ER library, and also for ultrasound for different departments like OB-gynecology, cardio, and also general imaging. Yeah, now you can see that we have 3 main product lines. First, a patient monitor and life support, in vitro diagnostics, and medical imaging system. These product lines are all in the first tier globally. Yeah, and also for our solutions, 19 out of the 20 hospitals are using Mandarin solution. You can see that there is some solution, some hospitals like Massachusetts General Hospital and Mayo Clinic, something like this. And also our cardiac solutions are used in 9 of top 10 US cardiac hospitals. Yeah, and these are the hospitals in the Europe that are using Mandarin solution. Yeah, and also Mandarin can support the global platforms that we can invite the globally experts that shares the information. Also, like you can see that we can invite the experts from ZSOG trainers to give us the training information. And also, you can see that we also have the ultrasound school that in Egypt to support the ultrasound training and the solutions. Okay, next is about the Mandarin's ultrasound solution. Let's see. Yeah. First, I want to know what's your expression about Mandarin ultrasound solutions. Yeah, you can see that there is some small, there is some machines with small monitors, or these hand-carried portable systems. Okay, sorry, there is a voice, I need to mute it. I'm so sorry. There is a mute voice. Okay. Okay. Actually, this is not a Mandarin solution. Actually, Mandarin solution should be like this. We have our full solutions from high-end product, so high-end to middle-end, even the low-end. We can support the card-based ultrasound system, even the hand-carried, portable, and even the fully touch screen. For our transducers, Mandarin can support the full transducers that can support all the clinical applications. Yeah, and why Mandarin can provide these solutions? You can see that our imaging R&D team, we have 5 R&D centers and also over 400 R&D staffs. Yeah, Mandarin can hear the customer's voice and develop our ultrasound solution. Yeah, and next, mention of the customer's voice. Let's see what are the difficulties in daily diagnosis. Let's see, first is complicated to operate. Different doctors works in different hospitals, so we used different ultrasound systems. Most of them are very complicated to operate. And second, poor image quality and need too much tuning of the parameters. Yeah, because most of the machines, the preset is not so good. So the doctors know better about the ultrasound system and tuning the parameters. Yeah, and next, need too much clinical knowledge and experience. Last is lack of training and timely customer service. Yeah, let's see, based on these difficulties, how about Mandarin solution? First, complicated to operate. Mandarin has excellent ergonomic design and workflow. You can see that we have 21.5 and even 23.8 LED monitor and 13.3 touch screen. Also, we have the customer design control panel. And also, we have card-based system, hand-carried system with touch screen, and also the fully touch screen system. And also, last one, you can see that we even have the ultrasound transducers with the buttons that can activate most of the functions. Yeah. And second, poor image quality and need too much tuning of the parameters. You can see that for this problem, we have excellent platform and fully transducer solution, and also optimized technology, imaging technology that can provide excellent imaging quality. Yeah. Also, for different applications, general imaging or gynecology, cardiovascular, and point of care, we can provide the advanced and intelligent solutions. How to understand this? Next, I will give you some solutions, especially for gynecology, to explain this. Yeah, you can see that we can provide advanced and intelligent solutions, from fertility solution to prenatal screening and even the postpartum health care. You can see that first, for the basic 2D images, color and PW, we have eye touch. It means that just press one button, the system can optimize the image quality and most of the parameters automatically. No need to let doctors change these parameters manually and step by step. Okay, and also for fertility solution, we have smart follicles that can calculate the follicle numbers and volume automatically. Yeah, and also we have smart ERA that can get the endometrium volume automatically, and you can see that this video, yeah, gets the endometrium volume automatically to evaluate the fertility capability. Yeah, and also we have 4D accuracy to check the smooth of the fallopian tubes. Yeah, and also for 3D and 4D, always doctor need to see the fetal face. Yeah, you can see that always there are so many occlusions in front of the fetal face. How to remove it? Don't worry, we have smart face. You can see that just one button, we can remove the occlusions very fast to get the excellent fetal face. Also, yeah, for the fetal biometry measurement, like some doctors just mentioned HC, FL, and AC. Yeah, traditional doctor need to draw this. For example, like the HC, doctor need to draw the cycle step by step. But now you can see that we have smart OB can get these parameters automatically. Yeah, just 2 clicks and 2 seconds to get these parameters very fast. Yeah, to evaluate the fetal growing status. Yeah, and also for fetal head, you can see that we have the automatically M mode and B mode to calculate the fetal heart automatically. Yeah. And also, yeah, for malformation diagnosis, we know that you can see the pie chart on the left. The CS, central nervous system, takes most of the part. Yeah, but doctors always need to get the standard plans to do the diagnosis. Traditionally, doctor need always, based on 2D or even 3D, they need to change the parameters and the orientation manually to get these plans step by step. It always needs more than 2 minutes, even the doctor with very much clinical experience. But you can see that we can get these results, standard plans, and give the comments, very important comments automatically, and even provide the measurement automatically. Yeah, you can see that this is the result. You can see just with one button, we can get the standard plans automatically and give some important comments of the anatomies and get the measurement results to help the doctor do the diagnosis very fast and accurate. Yeah, and also for postpartum health care, we have the exclusive smart pelvic solutions to evaluate 2D and 3D measurements automatically. Yeah, this is the 2D measurement. Yeah, you can see that just drop some points and can get the result to evaluate the organs information. Yeah. Okay. Next is the last difficulties is lack of training and timely customer service. For the training, you can see that Mandarin can organize so many offline hands-on training for the doctors, and also we can cooperate with our local partner and the society like ZSOG together to provide the certification for the doctors. Yeah, and also we can do the installation training for the doctors. These are the programs that we did before. Yeah, and also we have the globally platforms that can do the knowledge and information communication. Yeah, and for the customer service, you can see that on the left is the picture about in the COVID-19 severe situation. Yes, for this picture, we also have a sculpture in the headquarters. So you can see that Mandarin pays much attention on the customer service. And also, you know that we have our local partner, KDB, that can provide you timely customer service. Yeah, and also, okay, this is also information about Mandarin and Mandarin is ultrasound solution. Hope that Mandarin and our partner can provide you the better health care for you. Yeah. Okay, thank you. Thank you, everyone.
Thank you so much. Thank you so much for all that information. I think we've come to the end of our session. I don't know if we've got any questions for our presenter. Any questions? There are no questions in the chat box. So thank you so much for that. Just a reminder, if you haven't registered, there's a link in the chat box for you to register. So register so that you can get your CPD points for this CME. Okay, I think we are done for session 2.
Sorry. Yeah. Just I mentioned that we have our local partner, and I sent the information in the chat box. Yeah, if you have any demands, you can contact them. Yeah. Okay. Thank you so much.
Okay. Thank you so much. So this is end of session 2. I will kindly invite Dr. Mhlanga F. Mhlanga to take over for session 3. Thank you so much. Dr. Mhlanga, maybe I'll kindly invite our organizers to take us through maybe any things to communicate to the participants.
Thank you, Dr.
In the meantime, yes, whilst we wait for Dr. Mhlanga.
We're trying to contact Dr. Mhlanga. I'm not sure whether he's in the meeting or not.
He's not yet. I checked. I think he's not yet in the meeting. So our organizers may address participants.
I'm sure Dr. Mamadzi, you can temporarily take over chairmanship. We've had the challenges with our Zoom room being full, probably he had that challenge in joining as well. I'll try and get hold of him. But for sake of time, maybe you can just go ahead and introduce the session.
Hello. Apparently.
Come again, quiet, Dr. Moy.
You are muted, Dr. Moy.
Apparently, Dr. Chang is on the YouTube platform.
Oh, can you join now? There's space in the meeting.
Yeah, maybe Jerry can share for now. What's his sorting himself out?
Okay. Okay. Good afternoon, colleagues. I think I'll just start temporarily while I wait for him to rejoin. Thank you very much for joining this meeting, and we are grateful to the previous speakers. We have had excellent presentations. So we now welcome you to the section on sexual and reproductive health, which we've termed reproductive endocrinology. So to just kickstart this session, allow me to welcome Dr. Rumbidzai Majangara-Karaga. We are very happy for her. She's become the first person to have a full certification in reproductive endocrinology. So we've asked her to share experiences in the hope of inspiring other young colleagues who might want to follow a path. So Dr. Rumbidzai Majangara, please welcome to the floor.
Good afternoon, colleagues. I'm just in the process of trying to share my slides. Can you see my slides?
Yes, we can.
Okay. Let me just, okay, you can see the slides, right?
Yes, you can go ahead. You can see that.
Okay, okay. So I've been asked to discuss with you the subspecialty in reproductive medicine or endocrinology, just like Dr. Madzire has alluded to. I'm Rumbidzai Majangara-Karaga. So I trained at University of Cape Town, and I was mainly based at Groote Schuur Hospital. We have partner hospitals. We had partner hospitals within that district, which is Somerset Hospital, Victoria Hospital, and other smaller ones. So Groote Schuur Hospital was opened in 1938, and it's famous for the first human-to-human heart transplant by Christian Barnard. It's located within the Western Cape. It's essentially a first world of its own at the bottom of Africa, and the public hospitals there are usually well-equipped with good government funding or subsidy based on the patient's level of income, with access to advanced procedures for most patients, though there are still long queues as we see in our government hospitals. Within the department that I worked with, the Department of Reproductive Medicine unit, it was a freestanding, so they have all the subspecialties, the four main subspecialties. Within my department, we had 4 consultants accredited as subspecialists, including help from private subspecialists. There was also the availability of dedicated subspecialist clinic, and each clinic had an available consultant. And the advantage of this was that patients with similar conditions are concentrated, and so there is better organization of care, planning of resources in terms of investigations, and discussion of cases within the group. So I will discuss my experience in South Africa. This subspecialty is offered internationally, but I will discuss the South African context. According to the College of Medicine of South Africa, subspecialists are defined as OBGYNs who, having undertaken appropriate additional higher training, are recognized to have special expertise in the relevant field and who devote at least half and probably more of their working time to it. This higher degree of specialization indicates intensive training, experience, and expertise. So in terms of reproductive endocrinology, what is expected is that one acquires advanced understanding of endocrinology of the non-pregnant and pregnant woman, fertility problems in both women and men, as well as clinical competence in surgery relevant to fertility in these disorders. So the entry requirements are the general specialization in obstetrics and gynecology, and that one should be registered as a specialist obstetrician and gynecologist. In South Africa, there are 4 universities which offer training numbers to fellows in reproductive medicine, but at the moment, one of them is not really functional. So it's essentially University of Cape Town, Stellenbosch University, both these are in Cape Town, and then there's University of Pretoria. So in terms of course overview, this is a 2-year full-time program or 4 years part-time training in an accredited unit. And the components of training include clinical work. So this is daily clinical work, laboratory work, reproductive surgery, and there's a research component. In South Africa, one acquires a master's in philosophy of reproductive medicine. And then at the end of it all, there's an exit assessment where they assess your logbook that to make sure you've met all the training requirements. There's a written examination that needs to be passed. There's an oral examination in the OSCE OSPE format. And there's also the thesis, all of them which are marked to contribute to the final pass mark. And then in terms of gynecologic endocrinology, this involves evaluation and management of puberty disorders, both delayed and precocious puberty, the management of androgen disorders, disorders with menstruation, HPO axis dysfunction, both hypo and hypergonadotropic, thyroid, prolactin, etc., as well as the management of disorders of sexual differentiation and premature ovarian insufficiency. We essentially had a gynecologic endocrinology clinic every Wednesday, which started around 11 and would end up until 5. And in that clinic, before pre-COVID era, we would get even up to 30, 40 patients a day that we would all manage and be able to discuss as a clinical team. And then it also involves antenatal service to women with endocrine disorders, e.g. thyroid and diabetes. And then in terms of biochemical and endocrine laboratory work, this was essential. So we had a combined endocrine meeting that occurred every Tuesday mid-morning, and this included colleagues from the biochemistry lab, the chemical pathologists, the general endocrine team, pediatric endocrine team, and gynecologic endocrine team. And the emphasis was on understanding the indications, performance, and interpretation of basic endocrine profile, hormone stimulation or suppression tests. Now we're talking about the ACTH stimulation tests, the GnRH, HCG stimulation tests in endocrine disorders, as well as genetic testing. And then in terms of radiology, with reproductive endocrinology, it is expected that one, at the end of the program, should have acquired expertise in ultrasound of the uterus and ovary for the diagnosis of disorders using transvaginal ultrasound and saline infusion sonography. Diagnosis of polycystic ovary syndrome, you would find, I've seen some reports here because we use mostly transabdominal ultrasound. It's essentially a subjective impression that is written on the report without really telling us what is the actual follicle count, what is the ovarian volume, because sometimes with the transabdominal, you can't see the follicle count. You want to assess the ovarian volume, it is not written, but it's just saying there's no PCOS. So it's very important to you for the gynecologists themselves to be able to perform this ultrasound and come up with a diagnosis. So diagnosis of fibroids, adenomyosis, the new morphologic uterine sonographic assessment criteria. One requires to know that. Diagnosis of congenital uterine anomalies, evaluation of the endometrium regarding cycle variation during cycle monitoring, as well as endometrial disorders, diagnosis of early pregnancy and its problems, as well as a cervical length assessment, ultrasound for follicular tracking, and then obviously collaboration with the radiologists for complex cases or those that require 3D or MRI evaluation. And then hysterosalpingography, one is required to be able to perform it themselves, to be able to interpret it. What we noticed was that sometimes even reports that were coming from our radiologists within the unit, sometimes when we did assess the ultrasound, the HSG reports, we would find different findings, and our findings would then also correlate with what we find if we did a laparoscopy. So that's when the unit, I think essentially with reproductive medicine, it's important to be able to look at the HSG and make your own conclusion instead of just relying on what is on the report. And then one is also required to have acquired level 3 endoscopic surgery expertise. So there is the Gazier certification is compulsory. When I was a senior registrar, I know Clive and Gerard Hardicombe, part of the team for Gazier certification, did come to Harare and gave us some training, and they're still actively involved. So one, before the final assessment, one should have acquired the certification, the certification 1 and certification level 2, and should now be on the level 3 where they're accumulating cases for the final qualification. So the surgery that is performed is essentially tubal surgery. There still is a place for neosalpingostomy, but with careful patient selection, and also salpingoplasty, as well as reversal of tubal ligation. All these are also part of the logbook requirements. And then, so there is one required expertise in ovarian surgery, management of endometriosis. There are some experts, big surgeons who performing endometriosis surgery, so there is exposure to that and ongoing learning. Management of congenital uterine anomalies, for example, septum resection, though there are controversies. Today I'm not making a scientific presentation, but these are some of the cases that one will encounter and get expertise in managing. Management of fibroids, laparoscopic and hysteroscopy, it is required within the logbook. Management of polyps, management of Asherman syndrome, as well as cervical. In terms of cervical seclage, there's a lot of evidence coming up talking mentioning management of refractory cervical insufficiency. Those that have at least one failed previous vaginal seclage, use of abdominal seclage, and now the shift towards laparoscopic seclage. And in terms of infertility, evaluation and management of infertility based on all the things that I've been discussing already, but exposure to ovulation induction. So essentially in the unit that I trained, almost every single day in the morning, it involved monitoring patients on cycles, either ovulation induction, artificial insemination, or IVF-ICSI, with transvaginal ultrasound plus or minus endocrine monitoring as required. And then also there was evaluation for patients for oocyte donation, oocyte and sperm banking. We had fertility preservation procedures, and then we were able to evaluate and wake up patients and prepare them for surrogacy as well as adoption as required. And then in terms of andrology, a reproductive endocrinologist is supposed to be able to make a diagnosis and manage male factor infertility, the basic history, examination, and investigation of the male. And it is expected that one should spend time in the andrology laboratory and be able to perform a basic semen analysis, as well as surgical sperm retrieval on their own. And then, of course, there should be a basic knowledge and understanding of sperm selection methods, sperm cryopreservation, and their limitations. And then, of course, in collaboration with urologists and andrologists. And then in terms of the embryology laboratory, there is no reproductive medicine without an embryology laboratory and close collaboration between the embryologist and the reproductive medicine specialist. But one is required to then acquire knowledge, understanding of the running operational requirements and quality control of this laboratory. So in South Africa, they have a very, assisted reproduction has been present for a long time. So in terms of legal and ethical aspects, I think they are quite organized at the moment. In terms of self-regulation, in terms of the legislation, there are laws regarding what is permitted, what is not permitted, as well as the professional bodies. The SASREC in South Africa is providing guidance on on management of ethical issues regarding third-party reproduction, oocyte or sperm donation, regarding surrogacy and the like. And then there was also participation in international registries of assisted reproductive technology. The head of unit that I was at is Professor Silke Dyer. She is the director of the African Network of Assisted Reproductive Technology. This is the registry of assisted reproductive technology within Africa. And her whole team is was within the department at Grootegeluk Hospital, and I was fortunate to work with the team. And then other aspects, recurrent pregnancy loss. We also had a recurrent pregnancy loss clinic every Wednesday in the morning before the gynae endocrine clinic. And this was a dedicated clinic with full staff complement away from the maternity unit, and with good data capturing, most of the investigations provided within the hospital, all the necessary anatomic and endocrine testing, immunologic, that is controversial, but we didn't do much of that, and then genetic testing as required. And then also data collection, intensive database with promotion of research and a lot of international publications. And then in the mature women's clinic, this one was held every Thursday morning. And I suppose in our setting, we don't see much, maybe patients do not come to complain because we don't really offer that service. But this clinic did have a significant number of patients. This was for the management of menopausal disorders, vasomotor symptoms. And I managed to acquire a broad experience with the broad range of hormone replacement therapy options available. And then also the management of osteoporosis, from when to screen at 65, evaluation, bone mineral density, when to order one, how to interpret it, endocrine and biochemical testing, as well as the treatment of osteoporosis. And then genitourinary syndrome of the menopause, unresponsive to hormone therapy, to urogynecologists. They were within the unit. And then in terms of contraception and fertility regulation, it's the basic contraceptive issues that we know. But then with reproductive endocrinology, we're then expected to come in when it came to advanced procedures, for example, deep implant removal under ultrasound guidance rather than X-ray, using C-arm and general anesthesia. So there was a specialty clinic at Somerset Hospital, which was one of our which was within our department, where patients within the Western Cape were referred for this, as well as removal of lost IUCD. And then one was also expected to be competent in decision-making regarding contraception in patients with medical or endocrine disease and hormone-responsive cancer. And then in terms of research component, one is expected to have done a master's in philosophy, and I did one on the status of assisted reproduction in the public health sector in Africa. I'm still doing the write-up, and hopefully we'll have a publication from it. And so it had two phases. The first phase was to identify which countries in Africa offer assisted reproduction. And then the second phase was to actually approach those public health ART centers in Africa and learn about their experiences, how to set up, what are the challenges, what are the facilitators. I'm happy that I managed to get a good response from some, this was an online survey with interviews via Zoom eventually in the second phase, and I did manage to get some responses. Can you hear me? Hello?
Yes, we can.
All right,
Yes,
that's
we
fine.
can, Rumbi.
All right, that's fine. And then I also had an opportunity to participate in local and international conferences whilst I was in Cape Town. So this is one of the conferences where I met some of my colleagues that you can see. You can see the familiar faces. The ISGE and ESGE conference. This was essentially for gynecologic endoscopy. This was in 2019, pre-COVID era. And then also fortunate to have collaborations with other centers. So Cape Fertility is one of the private fertility centers in South Africa, where I think they from what they say, they get a very big proportion of patients from international, Australia, USA, etc. And I had an opportunity to visit them and interact with them throughout my 2 years. And then also Stellenbosch University, their consultants are also at Vincent Pallosi. This is Professor Thinas Kruger, the one that is known for the Tigerberg strict criteria. He's one of the directors at Vincent Pallosi Fertility Clinic, Prof. Igno Sibet, Gerard Honeycomb, and they were able to be some of my tutors. Thanks to COVID, we had free times in the morning this 2021. So every Tuesday and Friday, I had an opportunity to visit their clinic and learn and get mentorship from them and see what they were doing. And then, well, this is me on top of Lion's Head. This is Table Mountain. This was a frightening experience, but I enjoyed myself, had an opportunity to be on holiday for 2 years. And then this is the farewell dinner. These were my colleagues within the reproductive unit. Fellows with me on the right, another one in the middle, and some of our consultants. Some were not able to make it. So that's the end of my presentation.
Thank you, Dr. Majangara. Rumbi, I apologize for chairing the meeting late. I was joining through the YouTube platform, so I don't have speaking rights when I'm on that platform, because when I came, it was phone. But I think this is really eye-opening for me, and I appreciate your sharing the experiences. Whilst people are raising their hands if they want to, I saw a chat that asks, thanks, Rumbi, can you share financing options for colleagues who want to undergo such fellowships? What was your experience?
Okay. In terms of financing options, when you're going to subspecialize in South Africa, you are essentially self-funded, right? So the universities there do not offer any funding to internationals. I think one other thing I didn't mention was, so they always have, like at University of Cape Town, there are 4 training numbers, and there's always one which is reserved for an international fellow. So when one is going out, for example, I've left, now there's a fellow from Tanzania who's going to UCT. So it's quite competitive, and one needs to apply early, and one needs to continue applying, I think, just so that at least they know you have interest, and still apply to all of them. So that's one. And in terms of funding, it is self-funded. You can then approach several other sponsors. Reproductive medicine is unlike, well, I think fetal maternal medicine, because that involves fetal and maternal mortality, neonatal. So I'm sure they would get, I don't know, Dr. Lerenga, it's easy to get sponsorship, full funding, but with reproductive medicine, it's yet to happen for the full 2-year training. So you can apply to, the University of Zimbabwe offers staff development funding. So I was on a staff development funding sponsorship, and I'm grateful for that. It did manage to cover some of my costs, not full costs, but it helped a lot. And then some people in South Africa have applied for the Bates scholarship, but the problem is that the Bates scholarship has an age limit. I think it's 35. So most people, by the time they finish training in obstetrics and gynecology and on the specialist register, they are unable to apply for that one. And then I really don't know much more. I don't know, maybe one can apply for government funding, but what I just need to let people know is that it's important to once you get the place, just seek any kind of funder. So, because I haven't heard of one in Zimbabwe who says we will fund a reproductive medicine specialist. For example, myself, I just applied, I got the place. After getting the place and knowing that that's when I approached the department and said, I've gotten this position, but I have no funder. And I was fortunate that the department supported me and supported my application to the Staff Development Funding Committee. So that is something that people can do.
Thank you. So we can continue this discussion, and if at the end of the session we have some more time, we can come back to the chat box. At this point, and in the interest of time, I'm going to invite Dr. Moyo, who is a reproductive specialist who runs the Bulawayo Assisted Reproductive Center, and he's going to share with us his experiences with postmenopausal women. So over to you, Jeff.
Thank you, Felix. I'm trying to see how I can share my screen. I'm now lost. How do I go there?
There's a green button that says share.
I've seen it, but I'm not able to. Just 1 minute. Just 1 minute.
Okay.
I can't to do this. Just.
Are you using a Mac or you're using
Sorry, I'm using a laptop, but no, I'm using a laptop. It's taking me to a screen which I don't want. Let me just get out of this one. And get out of this one. Okay. Good. I'm sorry about this.
I am not. It's okay. I'm not seeing anything yet.
You're not seeing anything?
I'm just no, not from your screen. No. If you need some more time, we could switch to Bismarck if he's ready.
Yeah, I'm here.
Okay, let's give Jeff a couple of minutes, maybe 2 or so minutes. Otherwise, we can reverse the order, and then he can come at the end.
Okay.
He tries to figure out how to share his screen.
Okay, let me put this here. Right. Right.
Yeah, you have started.
Can you see anything now?
Yeah, I can. But it's a list of your desktop. Maybe you're looking for the particular presentation.
Yeah, I'm looking for the presentation. Yeah. Oh, there it is. Sorry about that. Old age. Okay, so I have to go to slideshow, right? Oh.
I think so, but so far I'm still seeing a list of your stuff.
You're not seeing my presentation. Can you see it now? Can you see it now, Felix?
Not seeing it. I'm still seeing your list of presentations.
No, maybe someone can, but
maybe let's switch to Bismarck if he's ready. And then maybe what you could do is to make sure that it opens up, it's ready, and then when Bismarck finishes, we come back to you.
Okay, let me try now. Let me try just a minute. Can you see it now?
Yes.
You can see it?
Yeah. If you can put it on slideshow now.
All right, thank you. Oh, God. Oh, it's refusing.
Click the icon, the box that's saying resume slideshow, or just click slideshow. There's a box, no, down on the blue, on your slide.
On my slide?
It's just where it's written assisted reproduction in perimenopausal women. If you push your cursor up, there's a box there.
Oh, this one.
Come to the right. Yeah.
To the right a bit.
Try that one.
No, maybe I can just present as it is, right?
There's something that is saying resume slideshow on top of assisted reproduction here.
Which one?
On your main slide where it's written Dr. Moyo, Nurse Medical School, the blue section of the slide on top, we can see a box.
Which says resume slideshow.
Yes, it's gone now.
Where is it?
It's gone now. You can click slideshow now, I think. Good. Yes, that one. Yes.
Right.
Right.
Yes.
Can you see it now?
Yes.
Okay. Oh. sorry about that, colleagues. I don't know. This is a new laptop, so it's just giving me problems. But thank you, Doc, for a wonderful presentation of what you went through in Cape Town. It's very in this subspecialization move that we have initiated. So I'm going to talk to you about the potentially controversial and ethically challenging subject that talks about, women. So my discussion, and then look at the risks, and then look at the commentary, and then and do some conclusions. Okay. So the case that I've chosen, I've got quite a number of these patients that I've looked after for the past 6 years that we've been doing this. I've just chosen just one because it's got a bit of spice. Most of them are non-individual. This lady she's a 51-year-old. Now she's probably 52, 53. She came to see me in 2017. She's a para-O with one ectopic. She was already post-menopausal. She had an interior deco company, had been married for 26 years. And when she came to see me, it was just like an informal chat. Said, Doc, you know what, we've been married for 26 years. A few weeks ago, my husband came and said, I now have a child. And we've been staying together and thinking that both of us have problems. So can you do a semen analysis on him? I did the semen analysis, and apparently the husband was fine. And then she says, also, now I also want I now also want a child. We evaluated the woman in terms of her infection screens. She was HIV negative, hepatitis negative, syphilis negative. She was a hypertensive patient, was just on HCT, and the BP was well controlled. The mammogram that we did was negative. Transvaginal scan showed a fibroid, and we subsequently did a myomectomy in April. We then, I'm just skipping a lot of steps. We then offered a fresh donor cycle in in November 2017. There's something that is okay. Sorry. And the donor that we offered here was 32 years old. We cultured 4 blastocysts in the lining by the end of the culture on day 5, 5AB, 3AB. That's a grading of the blastocyst. And she did get pregnant, but it was just a biochemical. Pregnant, and the 6 weeks scan showing around 7 weeks, and we did an MV. In February 2019, 3BB, and she did get pregnant, but it was a twins pregnancy, and the twins were all confirmed to be viable at a 6-week scan. The pregnancy itself was uneventful in terms of maternal issues until 24 weeks. At 24 weeks, she started bleeding. We admitted at the private hospital for bed rest and steroids. For almost 3 weeks, she was on bed rest and steroids, and the bleeding had sort of subsided. Then at the end of 27 weeks, one of the twins was noted to be now in IUD. We continued the bed rest for another 2 days, and then she started bleeding more profusely. And we finally did the cesarean section at 27 weeks and 2 days. That was the 27th of October 2019. The first twin was a macerated stillbirth. The second twin was did need to stay in hospital for some time and is now 1 year, 8 months and developing well. Today I got a photo of the baby. The young girl is standing, I think maybe walking as well. So there's something here, Felix, which is, I can't see the top of my screen. Okay, so the first IVF case was recorded in 1979. And the use of donor oocytes is recorded to be in 1983. Apparently, when they started using the donor oocytes, what they would do is they will do an IUI and then take the embryo and then implant it on the recipient. The technology has moved on now. Initial donor IVF was meant for women with premature ovarian failure, repeated IVF failure, and those with poor reserve. Now donor IVF has moved on, is now being offered for women with advanced age. And the first cases of donor IVF on advanced maternal age are recorded in the 1990s, making a higher proportion of our clinics because women tend to delay in the first women tend to delay having children because they have to go to school and pursue their careers. In our country, in the developing world, some will be delaying to have children for careers, but most of them will delay having children because they'll be seeking assistance from the wrong places. No longer sharing that. Okay. So initially it was thought that when you offer IVF and offer these postmenopausal women these donated oocytes, donated embryos, there will be problems with implantation. But then it was then found that actually implantation is not a big problem. Endometrial biopsies done on these appropriately stimulated postmenopausal women was actually similar to their younger counterparts. I think that's also our experience here in Bulawayo. I don't know what's happening in Harare. From the cases that we're managing with there are only about 2 where we're struggling to get endometrium to 8 millimeters. The pregnancy rates from these postmenopausal women is not different from the younger women. So when we have patients that are postmenopausal and we are intending to, it is important to involves checking for infections, including HIV, syphilis, hepatitis, chlamydia, doing imaging to check for medical conditions, including checking for newly diagnosed diabetes, and then also check other organs, like, for example, having to do a proper cardiac evaluation. This actually sometimes might need input from physicians. And then also looking for malignancy. We have to do a pap smear and mammogram. There's a sad story about a few years ago in our private hospital where someone had a donor IVF from South Africa, but they had not checked the breast and then eventually died from breast cancer. So when we evaluate, we want to make sure that if she has any medical conditions, they are well controlled and medically she is fit and can handle the stresses that are related to pregnancy. And then there's an important aspect of the evaluation that also includes counseling. We have to have sessions with these postmenopausal women to alert them to the increased risk of their medical conditions deteriorating and the stresses that are related to conception at advanced age. We also probably need to assess the support system. Is she married, and how will they be able to cope with a young baby at that advanced age? And then controversially, probably assess the financial stability. Someone might have the wish to have a but maybe can't afford any IVF. The protocol itself is not very difficult. I'm sure you, the doc who has just come from Cape Town knows that most of these things are not difficult. The recipient, who is the postmenopausal woman, goes through a preparation of the endometrium, which involves use of estrogen and progesterone. At the same time, you have to synchronize her with the donor. The donor will go through stimulation of gonadotrophins, and this is the scheme that's shown there is a short protocol. And then at retrieval, when we retrieve the oocytes, then the recipient starts getting progesterone. In terms of the risks, the papers that are listed there, they've shown that the postmenopausal women are at higher risk of developing hypertensive disease of pregnancy, renal disease, gestational diabetes, and they also have a higher risk of developing, and also a higher risk of undiagnosed breast cancer. Risks, they have a higher risk of low birth weight babies, higher risk of preterm labor, higher risk of fetal mortality, and the series on the papers that I listed on the previous slide actually showed that these poor outcomes are doubled in these women that are postmenopausal. In 2004, SRIM issued an opinion about the use of donor oocytes in women that are above 50. They revised it again in 2013 to address this controversial issue. To try and come up with an age of saying clinics must use this age is very difficult because no one knows how old is too old. But we have to balance the benefits and also harm, and also balance reproductive autonomy and the welfare of the child. Unfortunately, if we do a case and the woman is 50 and there's a problem, media tends to highlight the negative. So it's very difficult for a regulatory body to put up an age and say, okay, if someone is above this age, you cannot perform donor IVF. What we do is different clinics, they set up their own criteria on what ages they cannot go above. And some of the clinics, they sort of calculate how long will, how old, sorry, will the recipient be when the child is an adult, that is about 18 years. And they use the life expectancy of that country to say, okay, if the life expectancy of Zimbabwe is 70, therefore I can go up to about 52. I don't know the life expectancy in this country, but that's what other clinics do. We in our clinic we've got our own age limit. What are the arguments which are in favor of this paper? The arguments are that children, include their grandparents, and finds it okay that children can be raised by their grandchildren. Why not allow those grandparents to have their own children? Secondly, that lady who I presented is 52 now. I'm sure there are lots of us in this group who are in that age and are still probably thinking of having one for the road. So if it is allowed for a man to have a child at that age, why should we prejudice against women? So it's probably discriminatory to say women can't have, who willing, who are fit, cannot have children at a certain age when you can still allow men to have children at that age. And then the argument that they will quickly die, we have got lots of young women that are smokers, that have got risky habits, that are allowed to get pregnant and probably also die within 2 or 3 years. And women should have reproductive freedom. And the other last point that the society raised was that at that age, most of these families, they are financially secure. So they're actually better having a family at that stage than when people are young and still struggling. What are the arguments against? The arguments against, the first one is that the nature itself, by allowing a woman to reproduce from menarche to menopause, it sort of puts a natural limit. Therefore, if the doctors are going against that, it's probably morally wrong. And then parenting can actually overwhelm. One or both of the parents can die once the child is still young. And then the fourth point was that the risk to the women for new and worsening of medical conditions is increased at that elderly age. And there's also a high risk of perinatal morbidity and mortality. So their conclusion was that when you are about to undertake donor IVF for postmenopausal and perimenopausal, or any woman who's in that advanced medical age group, a thorough assessment is required, and a proper counseling is required to ensure that there is as low as possible risk that the pregnancy will be associated with poor outcome. And then in terms of conclusion, this is my personal conclusion. If we are going to offer postmenopausal women and perimenopausal women or elderly women a donor IVF, we need to provide, we need to do an extensive and thorough assessment to optimize the patient and ensure patient safety. And also, probably have to do more assessment and ensure the platform. In cases where the physical and psychological state of the woman is healthy, the outcome of this pregnancy is very good. That should be my last slide. Thank you.
Thank you. Hi, thank you, Dr. Moyo, and very nice on how old is old. I'm trying to go through these charts. Any questions from anyone? You may raise your hand and I can come to you. Dr. Moyo, did you manage to confuse everyone? Or they understood you?
probably will confuse them.
Anyway, as they think about the questions, thank you, Jeff. I'll call on Dr. Mateveke to give his talk on very complicated topic, endometriosis. He will tell us his experiences in managing these kind of cases. Please keep the questions coming into the chat box because we can go back to any of the three topics and take it up from there. Over to you, Dr. Mateveke. And thank you, Dr.
Thank you, Dr. Mhlanga, and thank you, Dr. Moyo, for managing to confuse all of us. And Rumbi, I must say congratulations and thank you for such an eye-opening and quite a very inspiring presentation. Yes, my talk today is to try and share with colleagues the experiences I've had with a few of my patients whom I am managing for endometriosis. I'm sure you can see the title for my talk is Psychological Quagmire. I think I found myself in this predicament and almost like complex situation where myself trying to manage somebody with chronic pain and you can't seem to give them some kind of relief at the immediate point that they actually want that relief. They really want this pain to go away. And they also can understand why you, as a trained gynecologist, you find it very difficult to assist them through their dilemmas. So I'm just going to try and walk with you quickly through some of these experiences and probably at the end try and share with you some of ways that we can try and cope with the situations as we try to help patients who suffer from this debilitating condition. So as an introduction, by definition, you have endometrial glands and stroma outside the uterine cavity. You can see this is a histological diagnosis, and the fact that it's outside the uterine cavity tells us that the disease is not with the uterus. The good thing is the benign condition, although chronic, sometimes debilitating, etiologies are known, and you tend to have quite variable symptoms and signs, and we call this condition the great mimicker. And there's a significant overlap of symptoms with other conditions, you know, like your pelvic inflammatory disease, irritable bowel syndrome, and so forth. 1/3 of patients can be asymptomatic, but we tend to find in 30 to 50% of women who actually present to the gynecologist with pelvic pain or
Hello. Please, if you're not speaking, can you be on mute? Admin, may you kindly make all people mute except the speaker? You may go on, business.
Thank you for that. And 30 to 50% of women with pelvic pain or infertility may actually end up with endometriosis. And again, it's a bit of a challenge having to come up with the actual diagnosis. And in one report from a survey in the UK, they noted an average of up to 7 years for one to actually come up with a diagnosis of endometriosis. This is a picture borrowed from Medscape, trying to just give a simple illustration of what endometriosis may look like. Sometimes it's quite obvious, but sometimes it can be very, very subtle. And you might actually really need the eye of an eagle to pick it up at laparoscopy. And indeed, it is a disease of theories, which I'm not going to go into at this point, but I will focus on the fact that the majority of the pain scientifically is explained by increased production of inflammatory and pain mediators, as well as neurologic dysfunction. But we also know we have so many diseases that can also coexist with this condition and also add to the pain. And it's classified as superficial peritoneal endometriosis, which the 3 cases I'm going to present, most of the endometriosis, we were fortunate that there was superficial and peritoneal endometriosis. You can also have ovarian endometriosis, as well as deeply infiltrating endometriosis that can end up involving your ureters, rectovaginal septum, your bowel. In terms of diagnosis, the gold standard is laparoscopy. But yes, you can have a high index of suspicion in patients who are coming with possibly, cyclical pain and the myriad of symptoms that may be suggestive of endometriosis. But laparoscopy is the gold standard with very good sensitivity at coming up with the diagnosis. So I'll go ahead and take you through quickly the first case. The lady is now 34 years old and has 2 children. When she first presented to me, that was in 2016. She was coming from the emergency rooms. I think this was for the umpteenth time. And, the emergency doctors at that particular emergency rooms where she was presenting were possibly feeling like, she was now acting up and possibly it became a junkie, so to speak, in terms of use of narcotics. So we noted that she had been chronically on narcotics and non-steroidals to try and manage her pain. And when she presented to us, we took her for laparoscopy. And surprisingly, when we entered, the pelvis looked pretty clean somewhat, but upon trying to evaluate further, we looked in the pouch of Douglas, and the only thing we could see was a little bit of pseudo pouching, not your classical endometriosis kind of pattern where you can see these red and powder band bands or white endometriosis. And she had also said that she wanted to have children, and we did go ahead and check her tubes, and unfortunately there was a bilateral tubal blockage at the time of chromotubation. Histology came out confirming that indeed she had endometriosis, and upon discussing our way forward, she just said, "Doctor, all I want is to have a baby. I know I'm suffering, but all I want is to have a baby." So what this meant was that possibly most of the interventions that we actually do for our endometriosis patients would not then be applicable, because there was no way she was going to then end up getting pregnant if we put her on those hormones. So we started working her up for IVF. Back then, the plan was to send her to Centon Fertility. And of course, during the waiting period, it was marred by severe episodes of pain during her menses, requiring admission and narcotics. And each time she presented to a new institution, sometimes, pain control would be sort of like withheld because they felt that maybe she had become an addict. She still refused contraception, and while we were still working up for IVF, somehow she fell pregnant. So you can never say never. Somehow she fell pregnant, and within 6 months, we had the 6-month delay because she was trying to raise the finances to have the IVF done in South Africa. She fell pregnant, and we delivered her by cesarean section. Fast forward to 2018, she still continued, refused contraception, says, well, that initial finding scares me that the tubes were blocked. If I go on contraception, what's going to happen? I'll just weather the storm and continue trying or go again for IVF until I'm done with my family. She then fell pregnant again in 2018, and she had a suction curettage. And in 2019, fell pregnant, and we delivered her again by cesarean section. Her condition in terms of the pain then worsened. I think after the delivery, by the time we then took her again for a repeat laparoscopy in 2020, she had been admitted to hospital almost every other week, and would require very strong narcotics to try and control her pain. She was still insisting that she doesn't want contraception. So we're now looking at our options to say, so what do we do? You don't want contraception. You don't want all these hormones that we use for endometriosis. So maybe let's go in again and relook. And we gave her the option of possibly excising the endometriosis as opposed to ablation. And I'm sorry for this pic, not a very good pic, but this is the peritoneum overlying the right. So I was just close to the pelvic brim on the right. And we noted these red patches, which ideally seemed like active red endometriosis on the right, and she had always been complaining of severe pain in the right lower part of her tummy. This was just showing, I think this is the last photo we took when we're doing dye studies, not coming out clearly, but there was minimal spillage on the left. The right was totally blocked. The spillage on the left actually came, I think, after insufflating more than 100 mils of methylene blue. Of interest was actually in the pouch, on the bladder peritoneum as well. There was an area again of white endometriosis. The pouch of Douglas, surprisingly at that time, where we previously took the biopsy, seemed not to have any significant obvious changes suggestive of endometriosis at that particular time. So we proceeded to go ahead to excise all the peritoneum around the area where there was red like lesions of endometriosis, and also the area where we had white endometriosis over the bladder peritoneum. That's the bladder, and that's the bladder peritoneum. And after the procedure, she never experienced any pain up to now. It's been more than a year. But the main challenges she went through during that time was that she was now having partner fatigue and marital disharmony. The husband was now out of work, in between jobs. She was also not consistently employed because of a problem. The issue of her being labeled by nursing staff when they go to hospital, because she was now frequenting the hospital for pain control. And of course, they were now in a significant financial black hole. You can imagine the expenses that they have to go through just for the admission and management in the hospitals. Because she was married initially, there was a lot of retribution from the in-laws. They felt like, she was playing up or playing truant, and at the same time, she was having difficulties having children until, fortunately, she ended up falling pregnant. That's why she insisted that she would never be on any hormones until she finishes a family. There were episodes that she would come in depressed, and we did send her for some psychotherapy with the psychiatrist that I do work with, which was quite very helpful. And we're happy that she's now pain-free 12 months after surgery. And she has actually gone on to form an endometriosis awareness platform on the various online platforms, and which is quite very active, where she actually actively shares a life story to women undergoing similar challenges. Case 2 was a 30-year-old, no chronic conditions, a newly qualified lawyer in a new relationship, and the fiancé was also considering having to marry her. But she came to me with a year history of a painful lump on the genitals, which she had noticed, I think, about 3 years earlier, was not very painful, continuing to increase in size. She also had reported severe dysmenorrhea for years, and sometimes heavy menstrual bleeding. And where she had been managed, she had been put on contraception as well as non-steroidals. There was very poor response to these medications. When I saw her for the first time examination, abdominal examination was really unremarkable, and vaginal examination did not demonstrate any possibility of a rectovaginal nodule. But there was a 2-centimeter right-sided, very tender pubic nodule, and there were no palpable inguinal nodes. And the main challenges she was actually going through, of course, being a newly qualified lawyer working for this law firm, there was significant disruption when it comes to her work, particularly during the time that she was having a menses, where she would actually go away from work for about a week or so. And you are in a new blossoming relationship that should be full of love, and unfortunately, intercourse for her was unbearable because of this nodule. Because during sex, you'd experience a lot of pain. And I remember in one of the consultations before we took her to theater, she actually came with a partner, and the partner was, you could tell the guy was very confused why this was happening to her partner. So our clinical suspicion was that she probably had pelvic endometriosis with potential extragenital endometriosis, that is the inguinal endometriotic nodule. So we took her to theater, diagnostic laparoscopy, surprisingly, nothing suggestive of endometriosis. The uterus, tubes, ovaries, a pouch of Douglas, the peritoneum, I would call it squeaky clean, so to speak. So we proceeded and excised the pubic nodule, and during the excision procedure, we actually noted chocolate-like contents. And we had discussed the issue of giving her some de-energist after the surgery, which she indeed consented to, and we managed to put her for about 3 to 6 months thereabouts, and she's actually off the medication and now off the de-energist, and she's pain-free to this day. This was just a report that came after the histology report, which you can see the pathologist did affirm that this indeed was endometriosis. So she actually had extragenital endometriosis in the form of an inguinal nodule. And the main challenges she felt or she experienced, of course, was the anxiety and the aversion towards sexual intercourse. And imagine she's actually in a new relationship, a ruined sex life, a relationship was at stake, employer impatience, and of course, having to deal with chronic pain. And she was also persistently worried that could she be having cancer because of this little nodule that she didn't understand. The last case I'm presenting is a 25-year-old. She's in a same-sex relationship, but she is bisexual. She had laparoscopic diagnosis of endometriosis in 2014. She was allergic to non-steroidals and morphine, which sort of like limited options for pain control at the time. And when she was referred to me, she came with the main problem was severe dysmenorrhea. Of course, she had a little bit of persistent pain in between her periods, but she wouldn't look forward to the next coming period because of what she would actually experience. And she also had annual pain, sometimes unscheduled vaginal bleeding, because she had had a Mirena in situ before the new relationship with the same-sex partner, because she didn't want to fall pregnant at that particular time. In the long term, she had told me that she still considers to have children somehow. So, of course, she was going to be in and out of hospital because for cyclical pain management was she would score her pain as something like 10 out of 10 every time. She would vomit. Sometimes when she came to see me at my room, she would be tearing and crying, crouching her pelvis, so to speak. So after counseling, we did offer to try the progestogens, de-energist in particular, which I gave her for a couple of months, but there was very, very minimal response to this treatment. She became depressive. The new relationship that she's in was now becoming a little strained because the partner is much older, and it seems like she was the one who was now taking care of her. And of course, she also had to deal with acceptance issues from her parents, who were always calling me about this whole issue as well in terms of her sexual orientation. And at the emergency rooms, of course, she was. They were now labeling her as a drug addict, so to speak. She didn't want surgery initially, so we opted to upgrade the treatment to Luprolide. Initially, we had planned on putting on Allergolix. Unfortunately, it's not available locally, so we then opted for Luprolide, which we gave a depot 1-month injection. But when we assessed her, she was saying there's no response. I think she went through the flare, and there was also worsening bleeding from the Mirena, and she really felt like all these medications, just like all the other medications, were not going to work for her, until eventually she agreed that let's go back and have a look, and we offered to excise any form of endometriosis that we see at the time of surgery. And in May of this year, indeed, we found peritoneal endometriosis that we excised. We removed a Mirena coil. This was upon her request, actually, at the time of surgery. Recovery was uneventful, and it's 1.5 months to 2 months now. And I saw her, I think 2 weeks ago. She's in a stable condition, not experiencing any pain. The last menstrual period was not as painful, although she still reported that she had a little bit of pain, but not as bad as what it was before. And histology did confirm that she had endometriosis. So this picture was just showing what we found at the time of entry. You can see a uterus. The tubes look normal. At initial, you would think that this is a clean pelvis. And then when we looked into the pouch of Douglas, you can see the uterosacral ligaments right there. On the right side, you can see the peritoneum, how it's oriented and clean. But when you then look on the left side, mind you, the ureter is also just close by right there. When you see on the left side, there was indeed this induration, and what I was describing as pseudo pouching is as if tiny little pouches, you know, the peritoneum is pulled up and down by the endometriosis. You can see it's quite different from that side. We didn't have any rectovaginal nodule at laparoscopy or even at digital examination. And again, we noted something similar to the first case where we've got these red patches that look like active endometriosis, again on the right side overlying the psoas muscle. We proceeded to try and completely excise. The only limit was a little bit of the ureter that was actually coming to get to the bladder, which was somewhere up there. So we had to limit our margins. We were worried that possibly this might not be complete excision. And we also did completely clean the peritoneum over the psoas muscle. And the biopsy did report that the peritoneum over the psoas muscle, there was no endometriosis. But you find that sometimes peritoneal endometriosis, due to the chronicity of the condition and medications that you can also receive, including leuprolide, they can alter, you know, the histological appearance of the endometriosis. But the excision in the pouch of Douglas was indeed consistent with endometriosis. And I'll go now in my last 2-3 slides to just talk about the psychological sequelae and what, you know, as medical doctors, we probably need to prepare and plan on how best we can help them. Physical and psychological trauma. They experience a lot of physical and psychological trauma because of the pain, and this then results in significant negative self-image, depressive symptoms. They become very anxious, and because they are chronically on these narcotics and drugs that are potential for addiction, some actually end up being drug addicts because of that, and that even worsens their situation, because even though they are addicted, they are still in this chronic pain. And when they go to the hospital, they are trying to balance their addictions versus the real need for the actual pain. And of course, they are prone to potential for drug adverse reactions because they are going to go on lifelong of prolonged therapy of these drugs. The marital and family challenges, as demonstrated in the few cases I've presented, and some may even go to lose employment. Stones and Cavigion in 2000 and 2014 actually wrote articles that were looking at the psychological sequelae and did describe that the negative self-image, mood, or anxiety disorders, alexithymia, and malfunctioning obsessive compulsive symptoms are more frequent in women with endometriosis than the general population. I must say the term alexithymia, to me, being a gynecologist, was the first time coming across this term. And it's essentially a personal trait where you become unempathic. You are unable to identify or describe emotions, your own emotions, as well as to identify how other people express their emotions. You literally become unempathic, so to speak. So what are our options? I would say a multidisciplinary approach, including counselors and psychologists, that can help to break this pain cycle. And teams for chronic pain management, as well as we were lucky that we only had peritoneal endometriosis, because if we're deeply infiltrating endometriosis involving your ureters and your bladders, definitely you need experienced surgeons, including colorectal surgeons and urologists, where sometimes it might actually mean reimplanting that ureter or removing a section of the bowel, because if it's endometriosis, the mantra is follow the endometriosis. If it's going into the ureter, go into the ureter, cut it, reimplant it, or reanastomose and the like. And chronic pain teams in well advanced, I'm sure at Grooteske, where Dr. Majangara was, they do have such kind of arrangements for these patients. What is important is shared decision making. And you need to set realistic expectations to outcomes, because if they come to you with chronic pain, by the time they come to a gynecologist, they would have been seen by so many other doctors, and they've tried a lot of treatments that are essentially not helping. And then they come to you, you tell them that I'm going to take away your pain 100%, and then that's not going to happen, then that's just going to worsen the situation for them. So you really need to set realistic expectations to say, look, you've had this pain for a long time. If we go in and do what we can in terms of excising the endometriosis or whatever medications you are going to give, you are going to get a little bit of, you are going to get some kind of relief. And each time you see them, you need to reevaluate your pain scores and tell them to expect that this might be, we might need a lot of time for us to get to a stage where the pain is well controlled. And of course, a stepwise pharmacotherapy approach is always good to review what medications they are on and consider upscaling your treatments and evaluate why they are not responding. Is it because they are not compliant, which sometimes does happen, or are they becoming intolerant to the medications, or there is actually non-response, which happens in about 20% of endometriosis patients who are on progestogens. 20% of them may actually not respond to that treatment, and you might need to upscale your medications. And considerations for surgery, which is laparoscopy, and there are also options for procedures like pre-sacral neurectomy or laparoscopic uterine nerve ablation. Reassurance and counseling plays a significant role. You are running a clinic and you have one of those patients booked. Make sure you create enough time, because they are most likely going to take more than your usual 20 to 30 minutes when they actually come into your consultation rooms. And you need to be very empathic, because if you give them that kind of a feeling that you are in a rush and you want to go, then things might not actually turn out well. And of course, issue of stress management and biofeedback therapy especially biofeedback therapy has been reported. So in conclusion, I would say endometriosis-associated pain can lead to so many significant non-physical challenges that also need to be actively recognized and addressed at the time of treatment. You need to set realistic expectations for outcomes of care. Empathy and patience are key, and you need to institute psychological management early, because most of the times when they actually come to you, they would have gone through years of trying so many things, and the issues of anxiety, depression, negative self-image may have already kicked in, and it's important to get the key people in the team, particularly counselors, to also come in and help in their management. I think this is my last slide. I thank you.
Excellent. Thank you, Bismarck. Do you find that you do need to liaise with other team members, or you usually do all this empathic and patient care on your own, or have you involved other people most of the time?
Yes, I involve other people most of the time. I mean, you get used to becoming empathic and counseling these patients, but we do recognize that there are people who are trained. So I do have colleagues, counselors that I also work with, and also psychiatrists that I work with. I also involve our anesthetists particularly when you're planning for surgery, for them to also see them when it comes to the issue of pain management. So yes, indeed, I do involve quite a number of team members to also come in the management. But of course, most of the time they are coming to see me directly when they're at their worst, when the pain is worse and they are crying and they are depressive. So we do initiate this counseling at the rooms and then refer them for further management.
Thank you. Any additional comments to Dr. Mateveke?
Yeah, now muted, Felix.
Sorry, if I don't see a raised hand here, I'm trying to check in the chats. There are no questions. I'm looking in the participants list. If you want to speak, please just unmute yourself if I haven't come back to you and ask any of the three panelists from this session. Please go ahead.
There's a question on the chat box from Busumani, Dr. Mhlang.
Yes, Dr. Mhlang, just if I can just also add to the question. Bismarck, have you had any cases of umbilical endometriosis? And also, what is your approach? Because umbilical endometriosis, you need excision, and I don't think you would use laparoscopy in that case. But I've had a couple of cases, maybe about 5, of umbilical endometriosis. My challenge was, if I now do open and do the excision of the umbilical nodule, what then of the pelvic nodules or situation there? Should I then make another fanestial to check the pelvic? I don't know, what's your experience if you have had any case of umbilical endometriosis? Thank you.
Yes, indeed. I've come across cases of. I actually intended to present one, but Zaza has not been worked up very well because she actually presented to me about 3 days. 3 days ago, she has had this umbilical nodule for the past couple of years with cyclical bleeding. Physical examination did reveal that she also has this huge rectovaginal nodule, which means she may have deeply infiltrating endometriosis. But to answer your question, umbilical endometriosis, just like the second case I presented with an inguinal nodule, it's a rare form of what we call extragenital endometriosis. But when these patients come, they need, yes, you will eventually have to excise the umbilical nodule, just like what we did with the pubic nodule. But I would say laparoscopy is the gold standard. You would have to go in laparoscopically to evaluate the pelvis for possibility of concomitant pelvic endometriosis. If it is there, you also have to address that. We were fortunate in our second case, she only had an inguinal nodule and the pelvis was clean. But sometimes you will find them concomitant extragenital endometriosis with genital endometriosis at the same time. I wouldn't advise open surgery for evaluation of endometriosis. Like I said, endometriosis can be sometimes very, very subtle. At open surgery, you have got difficulties sometimes of evaluating like your pouch of Douglas and checking your laterosacral ligaments and the like. And some lesions can easily be identified essentially under microscopy, so to speak. You need your telescope to magnify what you are seeing for you to be able to identify the endometriosis and deal with it appropriately. So I wouldn't advise an open approach, but rather a laparoscopic approach in general.
Yeah, that's
exceptions to the rule.
I'm afraid we can't quite.
Eventually available. Okay.
It's okay. Go ahead, William. We can now hear you.
Okay, fine. So I was saying, laparoscopy, this side is not easily available, and some of the patients are actually from the district and do some operations there. So the patient actually had an ultrasound scan of the pelvis, which had showed some masses in the pelvis, but then she also had an obvious umbilical nodule. So those are the cases where I'm asking, so what will be your best approach? We're also going to do open surgery because it's not available laparoscopy here. And so excise the nodule. And then what do I do with the pelvic masses that the scan would ever picked up? These are actually real cases. I have 2 patients who have got that. And they still complain, one of them still had pain during the cyclical pain was still there. So what's your
so my contribution to that, or my advice in that scenario, we need to appreciate that the best shot a patient with endometriosis, the best shot at getting maximum relief is very good surgery at the first attempt. So in situations where you might be limited in terms of offering the optimal care for that kind of a patient, even in the district, I think you would rather refer to the central hospital where they may have the equipment needed for the laparoscopy, and the people with the expertise to deal with the endometriosis laparoscopically, because you are putting yourself at risk of doing a suboptimal. You might remove the nodule, but still leave the endometriosis. Because if you leave endometriosis, even if when you've removed the nodule, and there is still either peritoneal endometriosis or ovarian endometriosis that you leave behind, the patient may not experience any relief from the pain. So I would rather in such a scenario, if you are in the districts or something like that, Matebeleland, probably refer to Mpilo, UBH, or something like that.
Yeah, I agree, business. I think we need to bring this to a close. I agree with your
All right, no, that's fine.
Okay, William, I think I agree with Dr. Bismarck. The other thing that we should do is just to keep an inventory of those people. And when the COVID situation settles down, those are the proper participants for workshops, because we'll have a list of who requires what, and we can then call them at the appropriate time. Thank you so much to all my participants who were presenting. I would really want to sincerely thank you. The next session is going to start at 2. I think we should take a short lunch break and then people can rejoin in time for 2 o'clock. Thank you. Have a pleasant short lunch.
Make sure it's always unmuted. And but mwana
zvekutamba.
Good afternoon. My name is Dr. Chimina. I will be chairing the fourth and last session of the day. We did very interesting presentation and very educative since morning. And I'll be chairing this session. So my three presenters will be Dr. Yemrai Bikwa and Dr. Emily Mukucha and Enesia Ziki. These women have very special interest in gynecology. And also Dr. Ziki has special interest and passion in research and is always keen to publish her work. So at this point in time, I will also want to ask everyone to keep their mics on mute. And if there are any burning issues during the presentations, you can keep them in the chat box, then you raise your hands during the discussion session. So at this point in time, I think Dr. Bikwa is now ready for a presentation. Over to you, Emrai.
Thank you, Max. Good afternoon, esteemed colleagues. Apologies for my bad voice. I'm recovering from a bad cold. It's been an interesting conference today, and we've enjoyed all the presentations. My topic is going to be postmenopausal bleeding. Can breast cancer be a cause? And the reason why we chose this topic was we're inspired by a case that was recently managed and is actually still being managed. So postmenopausal bleeding, the incidence about 14 per 1,000 postmenopausal women. Its incidence decreases with age, but the probability of endometrial cancer unfortunately increases. And we know that endometrial cancer is present in about 10% of women who present with postmenopausal bleeding. Of the endometrial cancer, it is unclear what percentage is associated with metastasis from other organs. The associations of postmenopausal bleeding and breast cancer are shared behavioral factors such as obesity, diabetes mellitus, metabolic syndrome, and also shared genetic susceptibility like BRCA mutation carriers, people who've got Cowden syndrome and so forth. Breast cancer treatment as well can trigger postmenopausal bleeding. As we know, tamoxifen use is famous for this. And then there's also the possibility of metastatic breast cancer presenting as postmenopausal bleeding or endometrial cancer. So now I'll just go through the case that was managed. This is the case of a 56-year-old para 3+1 patient who presented with postmenopausal bleeding. She had been menopausal for about 9 years and a history of breast cancer, which was diagnosed in 2012. It was managed with mastectomy, and she had 8 cycles of chemotherapy thereafter. She does have a positive family history of malignancy on the paternal and maternal side. And she's got a history of increased endometrial thickness, which was noted on an ultrasound scan in 2018, where she subsequently had DMC, and it was noted that she had ciliated metaplasia. 3 years ago, she was switched from tamoxifen to Arimidex, and she's been on Arimidex for the past 3 years. Her last 2 cervical cancer screening tests were unremarkable. On physical examination, it was unremarkable except for the right breast implant. Her biochemistry results, full blood counts, renal function, liver function were normal. A transvaginal scan that was done showed an endometrial thickness of 21 millimeters. Endometrial sampling done, there was no endometrium seen. So the doctor proceeded to do a diagnostic hysteroscopy, during which it was noted that she had a polyp and a submucosal fibroid, which were all removed on this sitting. On return of the histology report, it was noted that indeed she had an endometrial polyp and a submucosal fibroid. However, within the fibroid, they noted that there was nuclear pleomorphism, which was suggestive of metastatic carcinoma, most likely of breast origin. She was subsequently discussed in an MDT meeting, and the current working diagnosis is metastatic breast cancer with endometrial deposits. So currently she awaits a PET scan, which will most likely be done in South Africa. So metastatic breast cancer is actually more commonly deposits in bone tissue, lung tissue, brain, and liver. It's very rare for it to deposit in genital organs. Metastasis to the female genital tract in general from extragenital primaries are rare, and the most common sites of involvement are usually the ovaries and the vagina. Uterine metastasis accounts for about 4 to 10% of these, with 47% of these arising from the breast as the primary. Endometrial involvement of breast cancer is even more rare, and it's usually seen with lobular breast carcinoma. Presentation may be asymptomatic or with postmenopausal bleeding, and in some cases, it's just an incidental finding at autopsy. So in order to differentiate whether this is metastatic breast cancer or cancer that is arising from the endometrium primarily, this can be noted on histological findings. Metastatic carcinoma of the uterus is characterized by focal occurrence. There's lack of necrosis and absence of premalignant changes in the endometrium. This allows for suspicion of metastatic cancer, even if the history is negative for cancer. Immunohistochemistry markers can be used as well to try and determine the primary sites. So now I'll go on to speak on tamoxifen therapy. Tamoxifen, as we all know, is a selective estrogen receptor modulator with both agonistic and antagonistic effects. In postmenopausal women, it presents an agonistic effect on the endometrium, increasing the risk of simple hyperplasia, complex atypical hyperplasia, and endometrioid adenocarcinoma. It increases the risk of endometrial cancer by 4 to 6-fold, and this effect is dose and duration dependent. Postmenopausal bleeding in women on tamoxifen requires prompt intervention, and the first line for these women is to do hysteroscopy and a biopsy. In our case, our patient had been moved from tamoxifen to Arimidex, so that's why we started off with the PIPEL. There have been issues about around the use of levonorgestrel intrauterine system, if it confers any protective effect from endometrial cancer. And yes, it's been seen to reduce benign endometrial polyps and hyperplasia. However, data is insufficient on the risk of endometrial cancer. And there's also concern of its effect in patients in whom the breast cancer is positive for progesterone receptors and concern for recurrence. Some people have suggested routine screening for women who are on tamoxifen. However, usefulness of routine screening is doubtful and is not economically plausible. So we usually act on these women. It's preferred to act when they actually have symptoms of endometrial hyperplasia, such as postmenopausal bleeding. That should be the trigger for investigation. So what's the fuss about whether this is metastatic breast cancer or it's actually just endometrial cancer? Distinguishing metastatic carcinoma from primary endometrial carcinoma is important because the treatment of these two carcinomas varies. Uterine metastasis from breast cancer may not need surgical intervention because the disease usually, if it's now presenting within the uterus, is widespread and the prognosis is most likely poor. So these patients may just be candidates for palliation and conservative management. Yes, they might still go for surgery, but this will mainly be just for control of symptoms. On the other hand, if it's primary endometrial carcinoma, surgery is part of the primary treatment, even in those patients who've got a history of breast carcinoma. This will also help in appropriate counseling for the patient and expectations as well. So what have we learned from this case? In our case, our endometrial thickness was normal. And what we learned from this is normal imaging is not a reassuring sign in patients who are at high risk. So we should proceed with biopsy even if the endometrial thickness is within normal limits. Directed biopsy is ideal in high-risk patients. As you can see, this patient had a polyp and a fibroid, which may have been missed if a blind procedure had been done. Also, we should keep a broad base of differential diagnosis in postmenopausal bleeding, especially in women who are at high risk. Thank you for listening, and please let us stay safe. I don't know, we'll now entertain any questions or comments.
Thank you, Yemrai. I think the questions will come in during the discussion session. Now I want to allow Dr. Emily Mukucha to come up with the presentation, challenges in managing women with suspected Lynch syndrome in Zimbabwe. Those with questions you can hold on, then we'll discuss them when we go on to the discussion session. Thank you.
Thank you very much, Maxo, and thank you very much, Yemrai, for breaking the ground for us today. So in terms of gyne-oncology. So I'm going to take you through my presentation. I'm just trying to screen share here. Okay. Okay. All right. Thank you very much. I would like to say good afternoon to everyone on board. Thank you for joining us today and allowing me this opportunity to share with you my presentation today. Okay. So I'm going to discuss with you today about the challenges in managing women with suspected Lynch syndrome in Zimbabwe. Well, it's always a tug of war in trying to manage our patients here in Zimbabwe, whether it's Lynch syndrome or any other cases, due to many factors that are beyond our control. The hurdles that we meet as we try to manage this patient and try to provide the best patient care are sometimes beyond our control. Like as it depicts there, we might bring in everything that we have, even our dogs from home, but we still face great challenges as we try to map the best way forward for our patient. So this is based on a case that we recently managed, and I'm going to take you through a brief history of this case for us to understand why I thought this was important to share. So we had a case of Mrs. SB. This patient is a 56-year-old retired nurse who was para 5 or who is para 5. She came in presenting to us in our outpatient department with a 3-month history of postmenopausal bleeding. So the history is that about 15 years prior to this presentation, Mrs. SB was treated for T2N1MO colorectal carcinoma by the general surgeons in the private sector at the age of 41 years. She underwent surgery, and post-surgery, she did not need any adjuvant treatment, so they opted for close surveillance only. And after 5 years, they discharged her or follow-up, and she remained disease-free up to the time that she presented to us. She, at that moment in time when they saw her with the initial diagnosis of colorectal cancer, she did not have, they did not do a gynecology-oncology consult. So there was no involvement of the gynecology-oncologist despite the history, the family history that I'm going to give you right now. So she has a strong family history of colorectal cancer. Her mother died of colorectal cancer at the age of 48 years. And her eldest daughter died at the age of 32 years following a diagnosis of colorectal cancer, which was managed surgically and with adjuvant treatment also. So she died at quite a very young age. This patient on examination, basically of note is that she was an obese patient with a BMI of 38 kgs per square meters with a bulk uterus sized at 12 weeks. The blood workout was generally normal in all parameters except that she had anemia, which could have been attributed to the postmenopausal bleeding that she was experiencing. part of the investigations that were done included an ultrasound scan of the pelvis, which showed endometrial thickening with a lining of 19 millimeters. So the next step was to sample this endometrium. Unfortunately, she could not acquire a PPL due to expenses, which she alluded to us at that moment, and we had to improvise with a manual vacuum aspiration kit and a 4 millimeter Kaman cannula. So this endometrial sampling showed a histological result of grade 2 endometrial adenocarcinoma. She was discussed in an MDT meeting, and in this meeting, the grade 2 endometrial adenocarcinoma was confirmed on a histopathological review by the histopathologist. Then the radiologist reviewed a chest X-ray and abdominal ultrasound scan, and they noted that it did not show any metastatic disease. So the recommendation for her was for her to undergo surgery, which included a lymph node dissection. The reason why they opted for lymph node dissection was that patient did not have MRI imaging, which is ideal in patients being followed up for endometrial carcinoma. So we could not actually decide pre-operatively if we could not offer a lymph node dissection. So she had to go under lymph node dissection. So in the government sector, this surgery was delayed due to industrial actions. The patient lost patience with us, and then she opted to go to the private sector. Here she was offered total abdominal hysterectomy and bilateral salpingo-oophorectomy plus bilateral pelvic lymph node dissection. The final histology of this showed a grade 1 endometrioid carcinoma, which was confined to the inner half of the uterus. Unfortunately, due to expenses, the lymph nodes were not assessed. She could not pay for the lymph node assessment. And then the histological report also showed that there was no cervical involvement, and both the adnexia were not involved. So this tumor was then, she was then reviewed again in an MDT, and then a confirmation of figure 1A grade 1 endometrial carcinoma was made. The MDT recommended that the patient needed follow-up only. But at this point in time, with the strong family history of colorectal cancer and the strong history in the patient of colorectal cancer at 41 years old, and then a subsequent endometrial cancer, we were already entertaining we were already entertaining Lynch syndrome based on the clinical and family history. So in view of this, her specimen needed to be evaluated further to make a histological diagnosis of Lynch syndrome. So in Zimbabwe, we did not offer the further investigations that were needed for this patient. So our gynecologist managed to talk with the histopathologist in South Africa, who offered immunohistochemistry for free to try and further evaluate this case. So the specimen was sent to South Africa, and it had immunohistochemistry done. This showed partial loss of expression of MSH2 with complete loss of expression of MUT-L homolog 1 and post-meiotic segregation to proteins. And this was in keeping with what is known as microsatellite instability when dealing with Lynch syndrome cases. We'll discuss that further. So Mrs. SB could not afford further germline molecular testing to confirm the diagnosis of Lynch syndrome. So based on the immunohistochemistry and the family history, a presumptive diagnosis of Lynch syndrome was reached. And this meant that her children had to be invited for further counseling and screening. We went on to do that, but they indicated strongly that they were not able to come for these routine screening or follow-up because of the expenses that come about with that. So just a few recap, Lynch syndrome, we all know that this is described as an autosomal dominant. highly penetrant germline mutation disorder. So it runs within generations in a family tree. So it has a genetic predisposition to colorectal cancer, like in the case of our patient, endometrial carcinoma, ovarian, and other multiple extracolonic cancers, like those which involve the renal system and others. So the baseline lifetime risk of a patient who's got Lynch syndrome developing endometrial cancer is between 40 to 62%, while that for ovarian cancer is to 12%. Basically, it's just an aberration of 5 DNA genes, which are the MMR genes, known as the mismatch repair genes. These 5 include the MUT-S homolog 2, MLH2, MUT-S homolog 6, and those that I've listed there, the post-meiotic segregation 2 and segregation 1. So when these genes have an aberration or a mutation, they result in loss of production of their end proteins, which are the mismatch repair proteins. Subsequently, absence of these proteins will then lead to microsatellite instability within DNA molecules. And this is what is known as the hallmark of Lynch syndrome. So these mismatch repair proteins, you only detect their absence on immunohistochemistry. And then you need to do a further germline testing to look for the absence of the mismatch repair genes to make a definitive diagnosis of Lynch syndrome. Of note is that in women who have Lynch syndrome, the sentinel cancer is usually a gynecological cancer. In our case, it was actually colorectal before the gynecological cancer. So women whom you suspect based on the family history that they might have Lynch syndrome, you need to screen these women. So basically, we use the Amsterdam 2 criteria to try and screen the minority group of women whom we think have Lynch syndrome that would want to employ further investigations to make a definitive diagnosis. Basically, I think we all remember this, where we talk of 3 or more relatives with the Lynch syndrome associated cancer, and 2 or more of these should be successful generations, and 1 or more relatives is diagnosed before the age of 50. And then we should have ruled out familial adenomatous polyposis, and the tumors should be verified by pathological examination. So our patient met all these, where 3 relatives, a mother, herself, and a daughter, had a Lynch syndrome associated cancer. She actually had 2, and there were 2 successful generations from a mother to her, or from her to a daughter, and all of them were diagnosed before the age 50, and these tumors had a pathological evaluation. This is the best criteria. Forgive me for my pronunciation there. It's basically used to try and evaluate a patient who should go for microsatellite instability testing. So basically, remember, we talked about the proteins that cause a microsatellite instability within the DNA genome. So this is when we decide that if patients meet that criteria, they should have this further evaluation on immunohistochemistry. So it's how these immunohistochemistry results are interpreted based on this. So this is just a screening tool based on family history and clinical presentations. So to try and give weight to a diagnosis of Lynch syndrome, you need to do immunohistochemistry. This is also a screening tool. Then you need to do targeted germline molecular testing to offer the highest sensitivity for the diagnosis of Lynch syndrome. In the case that I presented to you, we only managed to go up to the immunohistochemistry due to the unavailability of resources locally, the high out-of-pocket expenses that the patient had to face for us to say, let's proceed and do germline molecular testing. So given this brief background of Lynch syndrome and the case that I presented to you earlier on as I started on, we tried to analyze, so what were the challenges that we faced with this patient that we might probably face with other patients that come with any Lynch syndrome associated history. So the challenges is that we do not have a locally available geneticist that would be able to screen, cancel, and maybe help in the diagnosis of these patients with suspected Lynch syndrome. So because of the lack of available local geneticists, we end up like the gyno-oncologists who end up having the burden of trying to cancel and trying to evaluate further whether we have or not have a diagnosis of Lynch syndrome, which is not actually the proper way of dealing with patients with Lynch syndrome. So we also face the challenge that this family has a very strong history meeting the Amsterdam 2 and the Bethesda criteria, and they need counseling and screening for the whole family and yearly follow-up. However, due to the expenses that come with these investigations, we cannot offer these kind of investigations to the family. Then the lack of the early MDT establishment, when the patient had a diagnosis of colorectal carcinoma 15 years prior to presentation, this should have been established. I'll explain a little bit further on why it was important. Then we lack lab services for immunohistochemistry, germline testing. We only have to rely on South Africa, our local neighboring country. And then the unavailability of a frozen section in MRI scans in the private sector. We explain a little bit further on the next slides. Then this patient, like we highlighted before, there was no earlier referral to a gynecology oncologist, which was actually paramount in managing this patient further. Why do I then say that these are challenges that we faced in this patient and that we'll probably face in the next coming patient with Lynch syndrome, and why are they important? So when we do not have a genetic available in our country, we merely rely on the Amsterdam 2 and Bethesda criteria to make a diagnosis of Lynch syndrome based on family history and clinical background. But literature has shown that this carries a low sensitivity. These two themselves are regarded as insufficient to be independent screening tools for Lynch syndrome. We still go back to the gold mark that immunohistochemistry, followed by targeted germline molecular testing, offers the highest sensitivity for the diagnosis of Lynch syndrome. This just puts to clear why a geneticist is necessary and of paramount importance in managing these patients. So when the general surgeons initially saw this patient 15 years prior, this history was still there. This patient had already had a strong family history suggesting of Lynch syndrome. The case really puts to fore why MDT meetings should be mandatory for all cancer patients and include all the specialists that should be involved. Like if earlier referral to a gynecology oncology team was done at the initial time, screening for endometrial and ovarian cancers could have been employed earlier. And this patient, by the time she presented to us, she had already completed a family, which means that at the time that she completed a family, if the gynecologist had known about this patient, they would have offered a risk-reducing total hysterectomy and bilateral salpingo oophorectomy. And this could have probably helped in not having to go through endometrial cancer again. So risk reduction surgery for patients with Lynch syndrome has been shown to be cost-effective and beneficial in reducing the gynecological malignancies which are associated with Lynch syndrome. Like remember, the major ones would be the endometrial and the ovarian. So once you offer this patient at completion of family, you have really reduced the complications that should face in future. This patient, if you recall very well, I noted that this patient underwent a bilateral pelvic lymph node dissection. There was no frozen section services available. The patient could not have an MRI scan due to its unavailability in the government, and it was also expensive for her to try and do it in the private. So the role of MRI scan in endometrial cancer is something that we cannot argue about. It has been proven that MRI scans in endometrial cancers are paramount. These MRI scans help to detect cervical stromal invasion. They also help to detect lymph node involvement and also to check for any adnexial involvement. So basically, when you talk of the role of MRI, you are trying to evaluate whether a patient will need a lymph node dissection during surgery or not. So the role of lymph node dissection for patients with endometrial cancer, it has been shown that to improve, it has not been shown to improve oncological outcomes in patients with low risk disease. However, it's part of the FIGO staging. And if omitted, like if you omit a lymph node dissection, there's a risk that cancer will also be understage. So in order to do this, we should be able to identify the small group of women where lymph node dissection is necessary. And this small group of women, in order to identify this, we also need an MRI scan. So if we then do it for this small group of women who actually don't need lymph node dissection, we can increase the morbidity without oncological benefit in women with low-grade and superficial cancers. So this was actually a challenge that we could not offer this patient prior to her undergoing surgery. Locally, we do not have laboratory services for immunohistochemistry or germline testing. So we sent these patients a specimen to South Africa. Apologies, the gynecologist, oncologist talked to the women, to the pathologist in South Africa to do these services for the patient for free. This allowed us to make a presumptive diagnosis based on the family history plus the immunohistochemistry. So Mrs. SB had a presumptive diagnosis after this immunohistochemistry. So the question then comes is, how many of our patients will afford to send their specimens to South Africa for immunohistochemistry? And how many will then afford further germline testing if we say we suspect Lynch syndrome in these women? This I've highlighted before, that her family now strongly needs counseling and screening for the whole family, but it has proven to be expensive. They actually alluded to that. We called them several times. They said we cannot afford to have these to have this screening test and follow up. She has 3 daughters remaining and a son. So her daughters ideally would need a yearly screening methods, of which top of the list would be a colonoscopy, and then we can offer a transvaginal ultrasound scan or endometrial sampling. However, colonoscopy is paramount in this case for her children, but they could not afford it and still report that they cannot afford it. So this remains a challenge for Mrs. Esby's family and any other family that comes with a relative who has been diagnosed of Lynch syndrome. Thank you very much, and back to you, Mr. Chair.
Thank you, Dr. Mukucha, for the clear, interesting case that you have just presented. I think just to say that I would also want to highlight that it is with great pleasure to say that most of these cases were thought to be rare, but with the help and energy that Professor Chirenje and Dr. Gusha have instilled in these young gynecologists, they have now developed keen interest in the subject of gyne oncology. Now I call upon Dr. Ziki to give us an update on the TADA study. Dr. Ziki.
Thank you, Max. I'm in the process of sharing my screen. Please confirm for me when you can see it.
Yes, I can see your screen, Anesia.
Yes.
You can go ahead, Dr. Ziki.
All right, I'm failing to see the screen myself. So sorry, I'm just trying to bring up my screen. Sorry, I can only see my preview. I'm trying to see to put it to put the whole screen up. Maybe you can move it for me, Max.
All right. Let me see. Can you put on the slide share?
Let me go back. Let me go to the presentation. Do you?
Yes, I can read the first slide, but
I can now see my screen. I don't know if you can. Okay, I'm able to move it as well. So maybe I can start if all is well.
Okay, cheers, you can shoot.
All right, good afternoon, everyone. Sorry for that short delay. So mine is essentially, my task is essentially presenting on a study that's going to be starting next week. It's the thermal ablation study on duration and access and anesthetics use also is the study, and it's going to be stability, the safety and effectiveness of thermal ablation in the prevention of that's affiliated with international cancer, clearly explained in the title of the study. So in addition to feasibility, acceptability, we're going to also be assessing the safety, the clinical utility and the effectiveness on thermal ablation on these precancerous changes. And the second objective is to compare the intensity of pain in women who are undergoing thermal ablation after the application of local anesthesia, whilst we use lidocaine spray with that, or after the woman has been given no anesthesia. Then the third objective is to compare the cure rates of lesions treated by two different durations of treatment. So in one arm, there'll be patients who are treated for 40 seconds, and in other arms, patients 30 seconds. So these will be the objectives of the study. And these are women who are supposed to have a histologically conceived treatment. I will go through them. Also, who are included are those who screen positive with colposcopically suspect eligibility criteria for ablative treatment. So in these women who screen positive at colposcopy, these are women who
your slides are not moving.
Receive biopsies. And the sample size of this study is going to be 100 184. So the eligibility criteria for ablative treatment will be if the entire squamous columnar. Yes, Dr. Dr. Chimina.
Your slides are not moving. You are on the first slide.
Ooh. Are you able to move them for me, Doc? Because they are moving on my screen. Let me just stop sharing.
Dr. Ziki, you can actually click on the slide that you will be reading. That usually works if the clicking of the next button actually doesn't work. Thank you.
I am, and immediately moving. And how's that?
It started to
Are
share.
they moving now?
Not yet.
Max, please.
No, we are not yet seeing your first slide at this point in time, but it's highlighting that it's about to start sharing. Yeah, we can see that slide with objectives on it. Hello, Siki. Enesia, are you still there? Okay, so Dr. Ziki is joining with another device. So let's just give a minute to join with another device. Okay, so while it's awaiting Dr. Ziki to connect using another device, I think the first cases that has been presented by Dr. Emily and Dr. Emran highlight the importance of MDT meetings. And I think as you are aware of, with the emergence of various specialties, we are currently having a twice monthly tumor board. It's on Zoom, and it's done every Thursday, usually from 5 p.m. So I will encourage all the people on this forum, if you can also join, it will greatly go a long way in improving the patient's outcomes. Okay, Dr. Ziki, are you ready now? It seems Dr. Ziki is having challenges in connecting. I think at this point in time, while it's will give you a chance to present on the update of the TADA study. I can open now the floor to questions for both Dr. Yemrai and Emily. You can either send in the chat box or you can raise your hands. Okay, it seems Dr. Ziki is having challenges with connecting, so I've kindly asked him maybe to give a summary of the presentation. So over to you, Enisia.
Hi, Max. So I think we can entertain questions while Dr. Ziki is joining.
Okay, that's okay. So I've now opened the floor. If there are any questions, clarifications, or contributions. As it stands, there are no questions as yet. Maybe Dr. Agusha, you can come in and give a comment.
What I wanted just to say was I think we've presented before the thermoablation study. What we wanted NCR to go was just to go through the protocol. She had very few slides. Basically, we are recruiting women who are between the ages of 25 to 59, either with an abnormal screening test, be it VIAC, be it an abnormal pap smear, be it an abnormal HPV test. We'll also be happy to have women who already have got a colposcopy and have a histologically confirmed diagnosis of HCIL. We're going to be recruiting these patients at Parenya Hospital on a Thursday. And these patients, pregnancy should be excluded. So we're going to do a pregnancy test to make sure that they are not pregnant. We are going to first screen them and see if they're eligible for recruitment. And if they are eligible for recruitment, they're going to undergo a colposcopy to evaluate the lesion and make sure that the lesion is amenable to treatment with thermal ablation. And these lesions are amenable to treatment. They should cover less than 75% of the cervix, and there should not be any suspicion of cervical cancer. There should not be any endocervical involvement. These patients are going to be randomized into 4 arms, either 20 seconds treated with or without lignocaine, or 30 seconds with or without lignocaine. So I think what NSC I wanted to highlight today was that the study is now opening for recruitment, and wanted to let the ZSOG community know that they are free to send their patients. They can phone myself or Dr. Simango or Dr. Ziki and Dr. Chimina, Dr. Bikwa or Dr. Mukucha. So we'll be happy to get patients either with an abnormal screening test or those with actually histologically confirmed HCU. We'll try to make sure that the process is seamless, especially for patients coming from private, so that they won't have any delays. So what NSC I wanted to do was to just alert the community that we're about to start recruiting, and we'll be happy to have support from all the gynecologists in Zimbabwe, Harare or outside Harare. Patients will be refunded for their travel allowances. I think that's what NSC I wanted to highlight. Thank you, Maxwell. Then my second story, before I just go off, is Emily has written a paper on the challenges of managing women with hereditary Lynch syndrome in Zimbabwe, and she has submitted it to the South African Journal of Gynecology for publication, and probably it's going to be published before the end of the year. So I just wanted to say well done to her.
Thank you, Dr. Gusha.
Thank you, Dr. Gusha. Dr. Simango, I can see your hand is raised. You can proceed.
All right. I wanted to bring up an issue, a point, I think, on recruitment of these patients, that because most of them are having VIAC for screening, we could look at the positivity results from the screening, from the histology samples for those who undergo excision, to try and get an idea of how many patients would eventually be suitable for screening in terms of those who have a proper precancer. I'm sure you have an idea. Even the chairman saw some of the results from histology. They show quite a low level of detection for true precancer, even on lip histologies. Thank you.
Okay, thank you so much, Dr. Simango, for your contribution.
Thanks, Max. So I think I'll just end up with a comment. I would just like to thank Enesia, Himrai, and Emily for having the courage to present at the ZSOG meeting. And I just want to say that the presentations were quite excellent. That would be my last comment. Thank you.
Okay, thank you so much, Dr. Gusha. Any contributions from the floor? It seems the presentation were clear and very interesting and educative. If there are no further comments or questions or clarifications, this was the last session of the day, so we have to hand over to the ZSOG executive to give comments and any housekeeping issues that they may have. Dr. Mateveke, are you on the forum? Dr. Magure, can you give some closing remarks?
Okay, thank you very much. Thank you. I would like to congratulate the scientific committee for coming up with a brilliant program for today. And congratulations to the presenters for excellent presentations for the day. And I wish everyone all the best. We'll meet you in the third quarter scientific meeting. Thank you very much.
Okay, thank you, Dr. Magure, for the closing remarks. I don't know if there are any other housekeeping issues. If not, I will have to declare this meeting officially over. Thank you so much. Stay safe.
Hello, Chimina. I think there's a
Hello?
comment in the chat window.
Hello?
Good afternoon. I think there's a comment in the chat window.
Okay, it's a comment from Dr. Melvin Lenge on the positivity rate. A rough estimate can be obtained. There is a blitz that was done on the screen and treat for precancerous lesions in September 2020 that covered a large part of the country. And I think over 500 women had screen and treat, and there were histological specimens sent to the lab. Maybe a good idea to lease this take on analysis of their bleeds.